Hello. Hello, guys. Hi. I think, are you able to hear, by the way? Yes, thank you. Just come back to that. Let's push to the corner. Okay. So, Ashwin J. Okay. Fine. What we are really doing here right now? Yeah, we have been discussing on the QRS complex. So I think what all we have done? We have done the P wave, we have done the PR interval, short PR and long PR, and we have done the uh, QRS complex to some extent. I think we should still are yet to complete the QRS complex magnitude. We have completed the width of the QRS complex and the intraventricular conduction delays, and now we need to see the height of the QRS complex. That's something very important to understand. So how will you find out what is the abnormal height? So now in the QRS complex, let us start with the magnitude of the QRS complex. Magnitude. In the sense, through the magnitude, I have two different definitions are there. One is the chamber hypertrophy, which can find out chamber hypertrophy, and second, probably I can think about low voltage complexes. Both are there. So, and you need to know the cause of both. So what are the causes of low voltage complexes, and what are the conditions that produce a chamber hypertrophy? Or in the fact, like how will you find out a chamber hypertrophy? We're not talking about the atrium because atrium is already done. And atrium should not come here because we are talking about the QRS magnitude. So we are talking about a ventricular chamber hypertrophy here. As far as the ventricular chamber hypertrophy is concerned, you have some criteria to know. So for example, let us start with left ventricular hypertrophy first, then we'll move to the right ventricular hypertrophy. So as far as left ventricular hypertrophy is concerned, you have many different criteria are there. The three different criteria, one is the Sokolov-Lyon criteria, and that's what they're going to ask you in exams most of the times. And at the same time, you have something called Cornell's voltage criteria, which I'll be discussing subsequently. And finally, you have some separate criteria like some R in AVL criteria, which I'll be discussing separately. So most important thing, and what they're going to ask in exams is going to be this Sokolov-Lyon criteria. That's the very important question as far as exams are concerned. So what do you mean by Sokolov-Lyon criteria? It just takes the S in V1, R in V6. So let us take the left ventricular power. We know to find out the left ventricular power, what is the power of the left ventricle? We need to find out the S wave in V1. So if you have the V1 here, you have the V6 here, and of course we know the septum is going to depolarize from left to right. That's not a problem. It's going to produce a small R and a small Q wave here. These are called as septal Q waves. And apart from that, we know once the ventricles are going to contract, or once the ventricles are going to depolarize, so this ventricular depolarization is of course going to bring the net force towards the left side because left ventricle is going to be more powerful than the right ventricle. We know that. So that is the reason why you get a bigger R wave and a bigger S wave here. So that magnitude is bigger. So what Sokolov-Lyon criteria basically attempts to tell is the fact that this S wave in the early precordial leads in V1 is a sign of a left ventricular power. So more the power of left ventricle, more it's going to be towards the left side. So the S wave will become more deep. That's the idea here. And at the same time, You can also understand if more the left ventricle pull towards the left side, this R wave will become more taller. So that's what they're trying to tell. So it's quite simple. It's not very difficult at all. So S in V1, so they're taking S wave in V1, plus they're taking this R wave in V5 or probably in V6, any one. So either R in V5 or V6. If it's more than or equal to 35 millimeter, then this is suggested to be the definition of a left ventricular hypertrophy. That is LVH. So I think you can get this. Why it's been told like this, I think it's very easy only. It's not very difficult to get. So this is Sokolov-Levin criteria. S in V1 plus R in V5 or V6 if it's more than or equal to 35 millimeter, and you give a number for that, and that becomes a diagnostic criteria for left ventricular hypertrophy. And this is the basic Sokolov-Levin criteria. Everyone are getting this or not? Yes, thank you very much. So you are able to get it. So this is Sokolov-Levin criteria. Then we have the Cornell's voltage criteria. So what do you mean by Cornell's voltage criteria? You have a completely different set of criteria for this. So in that you have S in V3, and you're going to take R in AVL. You're taking intermediate leads, S in V3, plus similarly if you're going to take R in AVL. So if this is going to be more than or equal to 20 millimeter, if it's the case of women, or if it's more than or equal to 28 millimeter in men. So you can remember why we take AVL, because AVL is a left-sided lead, and more the left ventricular power, more is going to be the force on the AVL. So this criteria is supposed to be a little more effective. I'll tell you why, according to the studies. So S in V3, plus we are going to take R in AVL. If it's going to be more than 20 millimeter in females, or if it's more than 28 millimeter in males. So this is what we refer to as something called the Cornell's voltage criteria. Could be a question in the exams. And R in AVL alone, which means AVL is a left-sided lead, we know that. Suppose if it is, if the left ventricular power is more, the AVL is going to show a bigger R wave because the net vector is pulled towards that left side. So R in AVL, if it is more than 11 millimeter, more than 11 millimeter. So in this setting, you can think about a left ventricular hypertrophy. I mean, if the patient has a normal axis, then this will be okay with that. Suppose if the patient is having a left axis deviation, if suppose the patient is having left axis deviation, then this criteria will become more than 18 millimeter. If the patient is having left axis deviation, the patient is having normal axis, then more than 11 millimeter is enough to tell that the patient is having a left ventricular hypertrophy. But if the patient is having left axis deviation, then the criteria will become more than 18 millimeter in that setting. So very simple, only three: Sokolov-Levin, Cornell voltage, and R in AVL criteria. Sokolov-Levin criteria, S in V1, R in V5, or V6. If you add more than 35, left ventricular hypertrophy. And next you have the Cornell's voltage criteria, that is S in V3 plus R in AVL. If you add together, if it's more than 20 in females or 28 in males, that is left LVH. Then R in AVL alone, if it is more than 11 millimeter in normal axis, or more than 18 millimeter if it's a left axis, then it becomes a left ventricular hypertrophy. Remember, one of the important points that you have to note about the left ventricular hypertrophy is the fact that this patient's, this criteria, whatever we are giving, are highly specific, which means if these criteria are satisfied in the ECG, then they must have left ventricular hypertrophy, but they are very poorly sensitive, which means they are not able to detect LVH properly. Both, any way you can understand. So remember, numbers anyways you have to memorize. The concept is fine. So why you are using AVL, why you are using S in V1 and R in V5, V6, that is concept that you understand. But number is based on statistics. It's based on the normal curve, and they found out through statistics, and that we cannot do anything. You have to remember the numbers for sure. Especially if you don't want to remember anything, all three criteria you don't want to remember. If you want to remember only one criteria for exam, remember the Sokolov-Levin criteria for exam and go. That will be the usual question in exam most of the times. Fine. Apart from that, you have a separate index also. That's called a Rommel-Testis index. I mean, I don't know whether it's understandable or not. I'll write again in a neat way. So that's called a Rommel-Testis index. They might give the name only. So if they ask you where you will use Rommel-Testis index, it will be for left ventricular hypertrophy. So the name is very important. It's a question. Once upon a time they asked this, that is Rommel-Testis index or Rommel-Testis score. Where will you use a Rommel-Testis score? You're going to use in left ventricular hypertrophy. So if you want to know what is the score that contributes left ventricular hypertrophy, score of more than 5 points according to the normal test score is definite LVH, and score of more than 4 and above, or you can tell just 4. Score of 4 is supposed to be a probable LVH. If the score is less than or equal to 3, it's unlikely to be LVH. So anything 5 and above, definite LVH, 4 probable LVH, and less than or equal to 3, it's supposed to be an unlikely LVH. Clear? So then we have right ventricular hypertrophy. How we are going to diagnose right ventricular hypertrophy? So 4 things that you have to know for LVH is the Sokolov-Lyon criteria, Cornell's voltage criteria. Then we have the R in AVL criteria. Then finally you have something called Rommel testis index or Rommel testis score. So right ventricular hypertrophy. Right ventricular hypertrophy is something very confusing most of the times, because it's going to produce an early transition, R wave in V1, V2 itself, and it will be bigger literally. And similar to LVH, for RVH also you have the Sokolov-Lyon criteria. But remember, in exam, whenever they ask Sokolov-Lyon criteria, always answer it for LVH, because this fact that for RVH also you have Sokolov-Lyon criteria, even the examiner might not be knowing it. So that's why I'm telling you. So certain examiners who might not know. So what is the Sokolov-Lyon criteria for right ventricular hypertrophy? So R in V1, remember, it's quite opposite. Here we have used S in V1 as a marker of left ventricular power, and R in V5, V6 as a marker of left ventricular power. Similarly, if you just use the opposite, you're going to use R in V1 here, because we know that must be a marker of right ventricular power. Plus at the same time, if I'm going to use S in V5 or V6, that must be a marker of right ventricular power again. If it's more than or equal to 10.5 millimeter, then you can call it as a right ventricular hypertrophy. Simple. There you used S in V1 plus R in V5 or V6. Just ulta it and learn R in V1 plus S in V5 or V6. If it's more than or equal to 10.5 here, there 35. So here it will become right ventricular hypertrophy, there it will become left ventricular hypertrophy. That's all. This is Sokolov-Lyon criteria for right ventricular hypertrophy. Then we have the RS ratio in V1. If the RS ratio in V1 is more than or equal to 1, plus at the same time, if the R wave in V1 is more than or equal to 7 millimeter. This is the number that you need to know. So R wave in V1 more than or equal to 7 millimeter. At the same time, RS ratio is more than 1 in V1. This is also a sign of a left ventricular hypertrophy, which means what I'm trying to tell is R wave in V1 is bigger, which is a sign of a right ventricular power. And RS ratio is more than 1 means we are trying to tell that R wave is bigger than S wave. So what are the conditions, differential diagnosis of a prominent R wave in V1? Of course, we know the first thing that should come into your mind is post-valve myocardial infarction. So it's an acute emergency, and if you don't treat that, the patient will die. So that's why that should be always coming into your mind first. Then it can happen in many other conditions, as I told you, right bundle branch block. It can happen. But remember, right bundle branch block will have white QRS. That's a really, really important point. Remember, you can diagnose RVH only in the presence of a normal QRS. In the presence of a white QRS, it's very difficult to diagnose a RVH, even if it is there. So if there is an RVH, and if you want to diagnose concretely through ECG electrocardiogram, then you should have a normal QRS. If you have white QRS and you have a prominent RS more than 1 and RV1 more than R in V1 more than 7 millimeter, if you have white QRS, it go towards a right bundle branch block only. So don't think anything else there. So apart from that, what are the other conditions? Apart from RBBB, you have right ventricular hypertrophy, which we have been discussing. Then apart from that, you have multiple other conditions like dextrocardia because of the lead reversal. You might have a prominent R wave, possibly. Then you might get in the setting of a lead malposition, where you're artificially creating different things here. Then you can get in Duchenne muscular dystrophy. So I'm going to just write as DMD, Duchenne muscular dystrophy. Then you can get in hypertrophic cardiomyopathy, especially if there is a septal HCM, septal hypertrophic cardiomyopathy, then certain pre-excitation syndromes. Pre-excitation syndromes are nothing but axillary pathway. Axillary pathway, especially if it's present in the left posterior region. Left posterior region. Okay. I mean, if you still can't get why this left posterior pathway or left pathway should produce this kind of big R, why in post-dual MI? So Madhusudan is asking why in post-dual MI. Madhusudan, did you attend the session in the morning? Now only I'm seeing, I'm shocked actually. Did you attend the session in the morning? Missed. So that's why. Scroll up slightly. Yeah, I've scrolled up. So I think you have not attended in the morning. So that is the reason why you're not able to get that. So see the morning session once again. So if you, I mean, the first thing we've been discussing for quite a long time. So that is the post-dual MI only. Okay. So now it's an interesting thing. Let us see what is the axillary pathway. So let us assume this is the heart. I draw my own heart most of the times. So if there is a left-sided pathway, so what will happen? So if you have a left-sided pathway like this, now in an axillary pathway like this, the SI nodal impulse will straight away jump to the ventricle, which means what is the first ventricle that is stimulated here? Okay, it is left ventricle that is stimulated here first. Okay, and whenever you reach the ventricle through axillary pathway, it is myocyte to myocyte conduction, or it is I mean, you are conducting through a specialized pathway. I mean, you are conducting through the normal conducting pathway. So of course, this is going to be a myocyte to myocyte conduction. Myocyte to myocyte conduction. Suppose if you are going to get a myocyte to myocyte conduction, and if the impulse originates first in the right ventricle, I mean left ventricle, first left ventricle, what is the pattern that you will get? You're going to get what pattern? Right bundle branch block pattern. Hence proved pre-excitation in the left posterior pathway. Of course, you're going to get the right bundle branch block pattern. And because it produces a right bundle branch block pattern, they can have a prominent R wave in V1. As simple as that. Clear? That's all. So, I mean, what you should not forget is post-dual MI, RBB, RVH. These are the principal causes of prominent R wave in V1. And you can remember that all these causes which I have told you can produce early transmission. I mean, early the transition from R wave to, I mean, becoming a bigger R wave. So we're talking about early transition and late transition. Right? So all these causes which I have told you can cause early transition. Is there anything called LV pacing? Yes, it is. There is LV pacing, Rejo, but it is something different. Like we have something called a cardiac resynchronization therapy, which is used in heart failure, where you use biventricular pacing. We don't separately use LV pacing because it needs some sophisticated techniques. I'll be discussing in heart failure section. What do you mean by CRT and what do you mean by biventricular pacing there? So then you have multiple other different criteria. Like for example, if you have a R wave peak time, so in V1, if it is more than 35 milliseconds, so then probably that you can think about right ventricular hypertrophy. Then if your S in V5 or probably in V6, if it is more than 10 millimeter, S in V5 or V6, if it's more than 10 millimeter in V5, if you're using in V5, or if it is more than 3 millimeter, if you're using in V6, then probably you can think about telling it's a right ventricular hypertrophy. These are some other criteria, but as far as I know, the first two are the most important. The Sokolov-Lyon criteria, which tells that R in V1 plus S in V5 or V6 more than 10.5 millimeter. And second is R wave is bigger in lead 1 compared to that of the S wave, and RS ratio more than 1, with R in V1 becoming more than or equal to 7 millimeter with a normal QRS, because if it's wide QRS, it becomes right bundle branch block. If it's a normal QRS, then you can think about a right ventricular hypertrophy. Clear? In DCM, why RBB pattern? Not in DCM. Typically in Duchenne, there will be certain areas of ventricle which will go for scarring. If there is time, I'll discuss about that. So in that setting, you might get a RBB. Can RBB cause RVH? So I don't know how to answer this question. No, actually RVH is the one that's going to cause RBB. And RBB, I don't think it will cause RVH. Clear right bundle branch block. A chronic right ventricular hypertrophy can produce, chronic right ventricular hypertrophy can produce right bundle branch block because of ischemia to the fibers. Okay, cool. I think we have discussed the chamber hypertrophy. Next, now it's time to discuss on the low voltage complexes. This is irritating. This is OneNote's biggest problem. Okay, then we have the low voltage complexes. Is there any criteria that you can tell biventricular hypertrophy? I'll tell you tomorrow. I mean, I'll ask you tomorrow. Is there any criteria or is there any pattern that will suggest a biventricular hypertrophy? If you tell now, it's good. If you don't tell now, I'll give you time till tomorrow. Biventricular hypertrophy, both LVH as well as RVH. Which disease will cause that? Yes, VSD. Of course, correct. VSD. Very important disease, which causes biventricular hypertrophy. Okay. Well, I mean, I'll tell you in V2, V3, V4, you'll be typically seeing a big biphasic complexes like this. It will be large, and you will see biphasic complex like this in V2, V3, and V4. And that's a sign of a biventricular hypertrophy. Yes, correct. Yes, he answered. Rijo already answered. It is Katz-Wachtel phenomenon. That is Katz-Wachtel effect or Katz-Wachtel phenomenon. So that's one thing that you have to know with regards to the biventricular hypertrophy, which typically happens in the setting of a VSD, large biphasic complexes in mid-precordial leads. That is V2, V3, and V4 is what we refer to as a Katz-Wachtel effect or Katz-Wachtel phenomenon. So what are the differential diagnosis for a low voltage complex? And what do you mean by low voltage complex, and how will you diagnose a low voltage complex in the first place? Is there any definition to tell low voltage complex? You have to take the entire QRS and you have to decide. So if the total QRS amplitude, if it's less than 5 millimeter in all the frontal leads, that is the limb leads, and less than 10 millimeter in all the chest leads, that is the precordial leads, and all the leads should show this. Every single lead should satisfy the criteria. Then you can call it as low voltage complexes. So what are the differential diagnosis of low voltage complexes? Very simple. If there is something that is impeding the current flow towards the leads, so there is something in between that is hiding the heart so that the current from the heart is not reaching the ECG leads properly. So first, you can talk about tamponade or pericardial effusion. So remember, tamponade is different. A simple pericardial effusion is different. Both are different. So in that setting, fluid is impeding the current so that it will not reach properly to the leads. Second, you have COPD. COPD here, the lungs will be hyperinflated. That can act as an impedance to the current flow. Then severe obesity. Here, fat will be there, which can basically impede the current flow. Or the myocardium might become extremely thin in the setting of a cardiomyopathy. Because in cardiomyopathy, the myocardium sometimes might become, especially dilated cardiomyopathy, the myocardium might become extremely thin and they will not develop sufficient power to give a good voltage complexes. So that can produce low voltage complexes. Apart from that, hypothyroidism because of weakly contracting heart. And usually this kind of low voltage complexes in hypothyroidism will be seen in mixed edema only. Because hypothyroidism produces weak contractions. At the same time, hypothyroidism can produce effusion also. A lot of things can contribute to development of low voltage complexes. Remember, cardiomyopathy can be either DCM, direct cardiomyopathy, or even it can be restrictive cardiomyopathy. Restrictive cardiomyopathy is basically caused by infiltrating diseases. What are the examples of infiltrating diseases like amyloidosis? Amyloidosis. Then probably you can think about myocarditis, sarcoidosis. So many entities are there. So amyloidosis is something which I want to really tell. Then I can write myocarditis, which can also precipitate DCM and heart failure over a period of time. Then we have certain tumors that can infiltrate the heart and they can produce low voltage complex because tumors are acting as impedance here. Then you can get in constrictive pericarditis. In large pleural effusions, especially on the left side, large left-sided pleural effusions, the fluid around the pleural space can basically act as an impedance here. Or severe edema anasarca, or sometimes large left pneumothorax, usually a tension pneumothorax, can result in development of low voltage complexes. But as far as I know, the most important cause of low voltage complexes will be tamponade, effusion, which is very important for exams, COPD, obesity, probably hypothyroidism, and some cardiomyopathies and myocarditis. So these are 6 causes that you have to know as far as exams are concerned. So a lot of infiltrated diseases are there. So you can write any infiltrated disease can produce low voltage complexes. So tamponade, COPD, obesity, cardiomyopathy, hypothyroidism, myocarditis, very, very important causes of low voltage complexes. Now we have finished off the QRS height also. I think we know the LVH now, we know the RVH, and we know the biventricular hypertrophy, Katz-Weierstrass effect, and we know the low voltage complexes as well. Apart from that, there's another entity with respect to the QRS complex. What is the entity called? There is something called electrical alternance that comes under the QA only. QRS complex only. What do you mean by electrical alternance? What do you mean by electrical alternance? Usually it is seen in tamponade, not a simple pericardial effusion. Generally it will be seen in tamponade. I have an ECG for that. So which will clearly show that it is a electrical alternance. I think this is the one. So what do you mean by electrical alternance? It can be told in 2 ways. Either you will see a positive, negative kind of a complex. So which is typically shown in this particularly. You can see one complex points down, one a little up. So varying amplitude. And at the same time, or you can see in lead 2 where it is tall, small, tall, small, tall, small. So this kind of complexes. So varying amplitude, or like it just changes every time. So this is due to a huge fluid around the heart. So in a tamponade, the heart swings around the pericardial fluid with every beat from one direction to another direction. So that is creating this kind of varying amplitude with each beat. And this is what we refer to as something called a electrical alternance. Electrical alternance can be seen in many, many conditions, but in exam, you should be talking only about tamponade. Tamponade is a classic cause of electrical alternance. When you see this kind of ECG, it must be definitely tamponade only. And there are 3 quintessential triad of changes that we'll see in a tamponade. One is the sinus tachycardia, second is low voltage complexes, and third one is the electrical alternance. If you have these 3 findings, so definitely it must be a tamponade. So if I ask you where will you see the P wave alternance? P wave alternance. Can you tell where you will see the P wave alternance? Alternating height of the P wave. Once again, pericardial effusion and tamponade. So once again, it will be seen in pericardial effusion only, and it's a pathognomonic for pericardial effusion, P wave alternance. If somebody is able to tell T wave alternance, where will you see T wave alternance? That's really, really good. If you see T wave alternance. Varying amplitude of T wave. No. If somebody is able to tell that, is really, really good. Delta. Day. Not hyperkalemia. Not hyperkalemia. I am Vengat 2004. I am Vengat 2004 means you're born in 2004. Vengat. If you are born in 2004, then I feel you are only 15 years or 16 years of age. Oh my God, you are preparing for NEET UG and NEET PG together. Okay. No, okay, 24. Fine, sorry. I misunderstood. No, T wave alternance you can basically see in long QT syndrome, especially this is very pathognomonic for long QT. If you have varying amplitude of T waves, so that's a sign of a long QT, and there is a high risk of death is there. I think even though I made fun of him, he's actually right. What he's trying to tell is there is a high risk of death with T wave alternance, sudden death especially, because it's a sign of a long QT syndrome. Clear? So that's T wave alternance. So P wave alternance, pericardial effusion, electrical alternance, tamponade, And T wave alternance, long QT syndrome. Clear? This is a very important question. So T wave alternance, if they ask you where you see, you go for long QT syndrome. So I think we have covered in and out about the QRS segment. So there's nothing to discuss more about the QRS segment. Now comes the problem of this one. That is, we need to discuss on this particular area. What is that area? What is that area that we are seeing here? The AT segment, ST segment, correct. That's an ST segment. So this is what we are going to discuss next. So I think I have to go down again. Okay, we are discuss on the ST segment. ST segment. So already we have discussed enough about that. ST segment, basically you can tell it can be elevated or it can be depressed. Elevation we know at least more than 1 millimeter in at least 2 anatomically contiguous leads. And we know the exceptions as well. I'm not going to tell once again. If you want to tell, I'll tell. So in V2, V3, exception is you need to have at least more than 1.5 millimeter if it's a female, or if you need at least more than 2 millimeter if males more than 40 years, and more than 2.5 millimeter if males less than 40 years. That's in V2, V3, but in other leads, V7, V8, V9, and V4R, you just need more than 0.5 millimeters. So this is the thing that we learned in the morning. Okay. So this is the elevated ST segment. And if you want to know about the depressed ST segment means more than 0.5 millimeter. I discussed all these things. 0.5 millimeter ST depression, at least in more than 2 contiguous leads. So this is called as a significant ST segment depression. And we know what ST segment depressions are dangerous: horizontal ST segment depressions and downsloping ST segment depressions are basically dangerous, and upsloping ST segment depressions are basically not really dangerous. We know that, we have discussed already. And where will you measure the ST segment? Elevation as well as depression. As I told you, if the heart rate is less than 130, this is standard. Then in this setting, you have to measure at 80 milliseconds from the J point. From the J point. So if the heart rate is more than 130, in this scenario, you have to measure at 60 milliseconds from the J point. So this is a standard, area where, standard point where you have to start measuring the ST segment for both elevation as well as depression. So ST elevation 1 millimeter, ST depression 0.5 millimeter, but there are some exceptions for ST elevation. We know that in V2 and V3 and in right side and posterior leads, there are some exceptions for the same. So what are the differential diagnoses for ST elevation? What are the DD for ST elevation? We know. And you're going to start with the first DD. Acute STEMI. The first DD is acute ST elevation myocardial infarction. So of course, we know that should be the first DD for ST elevation then. So what will be the nature of this particular ST elevation? That's what we're going to see. At the same time, what will be the clinical background and what will be the investigatory workup in this. So nature of this ST elevation, we know how it's going to look like. So nature will be something like this. So most importantly, you have to know that this elevation produces something like a tick mark sign like this. Like you can see this tick mark or a check mark sign. So that's the nature of the elevation. So, and it's going to be more convex in nature. Whenever examiner tells a convex ST elevation or this kind of elevations can be, you can see this kind of elevations as well. Like, let me draw once again, where you can see this kind of elevations. You see these kind of elevations also, it's dangerous because these are basically referred to as something called tombstone type of elevations. So these are typical of a STEMI. So which means convex, and they can be like a tombstone also. And they can produce this tick mark like this also. All these things are suggestive of a STEMI only most of the times. But even though you cannot predict based on the nature of the ECG and all, but you should be careful about these words. Convex, tombstone type elevations, always the examiner is trying to tell that the patient is suffering from a acute ST elevation myocardial infarction. And of course, if you put a smiley, it's going to be very sad. And this is because of the convex ST elevation. So it's a sad smiley. Clear? So it's a sad smiley. So that's a tombstone elevation. Clinical background, the patient will have ischemic chest pain. We know that. So ischemic chest pain in the sense like, what do you mean by ischemic chest pain? The patient will be having a substernal pressure or a substernal pain that will radiate to different areas in the body. Like, for example, it can radiate to arm, neck, jaws, shoulders, and even to the, like up to the fingers and hands. They can radiate up to that. So radiates to left shoulder, significant for MI, or radiating to both the shoulders, have more odds of having an MI. Which is having more odds of having an MI? Left shoulder or both shoulders? If I ask like this, you should be easily able to tell it's both shoulders. Both shoulders are having more odds of having a myocardial infarction than only the left shoulder. Fine. And lab parameters, we know troponins are going to be increased, and coronary angiogram is going to show a complete occlusion of a particular vessel. There'll be absolutely no flow. On the second, it can be something called pericarditis. So most of the times acute pericarditis, not chronic pericarditis, like chronic constrictive pericarditis will not cause any ST elevation. Acute pericarditis can produce ST elevation. Usually what will be the nature of elevation in the setting of pericarditis? They're going to be something like this. This will be the nature of elevation in the setting of pericarditis, which means when you draw a smile, so which means you can see that's a concave elevation, not a convex elevation. If you see here, if you take this is the ST segment, and if you see at the J point, the arrow will be sloping up. Whereas if you take this the J point, and if you take the ST segment 80 milliseconds from the J point, the arrow will be sloping down. So that's what we refer to as something called a concave elevation, and we know that. Concave elevation, we know that. Okay. So that's the reason I tell whenever you have a convex ST elevation, the arrow points up, and if you combine the area, it will go up. And whenever it goes up, it means that if you don't treat the patient, will go fast up. So pericarditis, the arrow is showing down, which means it's going to stay in the earth for a longer time. So that is pericarditis. And if you put a smiley here, because it's a concave elevation, they will have a happy smiley. So because it's a concave elevation, and this elevation can also be called as saddleback elevations, because we know why it is called a saddleback elevation, because there is someone who can sit on the back of this animal that is nothing but the camel. So which I'm drawing, even though it's a worst camel which I'm drawing, but still. So this is what we call it as a saddle. Okay, so this is like a saddle, and you have a hump here. Nobody can sit on the hump, of course. So if you sit on the hump, and if you're a boy, like I cannot really tell. I can only tell no, because that's painful, really. So you can't sit on the hump. So, and you have to sit on the saddle. Clear? So this is how you can sit on the saddle. So this is basically something referred to as a concave type of an elevation. Concave type of an elevation. And of course, it's going to result in something called a saddleback kind of elevation. So concave saddleback goes towards pericarditis. And clinically, you will have a chest pain, of course, but they may not be ischemic. And ischemic chest pain means typical radiation will be to the shoulders and all these things. To shoulders, arms, neck, and all these areas. But what will be the classical radiation site as far as the pericarditis pain is concerned? Anyone can tell where it will radiate? Pericarditis pain. Radiation site for pericarditis pain. Correct, trapezius. That's correct. Trapezius is a very important word. Radiates to trapezius. That's a very common question in exam. Lab-wise, if you have only pericarditis, troponins will be normal. There won't be any problem in the troponins. If you are having only pericarditis, it won't be an issue. But remember, many times you might have myopericarditis. You might be having underlying myocarditis also. If you have myopericarditis, troponins can be elevated because it's a damage to the heart. So there can be elevation of troponins in this situation. But only pericarditis, troponin will be normal. There won't be any problem. And of course, in myopericarditis as well as pericarditis, coronary angiograms will be definitely normal. So there's no vessel occlusion here. And most of the times in exam, you'll have a history of viral infection in the past. Like maybe 1 or 2 weeks ago, there'll be a history of viral infection, like a upper respiratory tract infection. And you do have stages of progression with regards to pericarditis also. What is the stages of progression? we can see this image and we can understand. Yeah, these are stages of progression. What are the classic findings of a pericarditis? In the sense, what will be the classic finding? So you can see this is the P wave and this is the PR segment. And you can see the PR segment is depressed. That's very classic of a pericarditis. And at the same time, I mean, it's very difficult to take what baseline you're going to take. If you take TP segment as the baseline, there is a small ST elevation will be there. Take the TP as the baseline, which should be done. There's a small ST elevation is there. And it's more of a concave type of an elevation or a saddlebag type of an elevation. So you have ST elevation and you have PR segment depression. And at the same time, there'll be something called a TP segment downsloping. I'll tell you that. This is a T and you have a P wave. Next, that's called TP segment downsloping. This kind of TP segment downsloping is what we refer to as something called a Spodek sign. So TP segment downsloping. So PR depression, TP downsloping, ST elevation, and TP segment downsloping. So remember, mirror image of this can be seen in AVR. Mirror image in AVR. So which means what you will be seeing? You will be seeing a PR elevation, ST depression, and a TP segment upsloping, TP upsloping. So which means exactly opposite to what you see here, you will be seeing in the AVR. Mirror imaging. PR elevation in AVR, ST depression, and TP upsloping. And this is a stage of transition where you might have a completely normal ECG, transitional stage. And after that, you might have starting to develop T wave inversions. So then finally, you'll have a normal STT area. So which means there won't be any problem after that. This is the complete normalization. So first, all the changes, ST elevation, PR depression, and TP segment downsloping, reciprocal in AVR, that is PR elevation, ST depression, and you have a upsloping TP segment. And after that, there will be a stage of transition phase, that is a normal ECG. Then you will get T wave inversions after that. Then finally, you will have a complete normalization of the STT segment. So these are the 4 stages as far as the pericarditis is concerned. Usually they won't have reciprocal changes. To understand that, it's important to know the ECG of pericarditis. This is one example ECG of a pericarditis. Usually pericarditis is supposed to have a global ST elevation. That's what your textbooks will tell. You'll have global ST elevation, which means you will have ST elevation in majority of the leads. That's what the books will tell. But as far as I know, very commonly pericarditis will produce ST elevation in inferior and lateral leads only, to an extent in 1 and AVL. So very commonly, these are the leads that will be affected, inferior and lateral leads. Spelling, Spodek. Clear? So now I'm going to write only SPO. You fill whatever you want there. Clear? Spodek sign. Understood? Okay. So you have 2, 3 AVF and 1 AVL and V5, V6. These are the areas that are commonly going to have ST elevations usually. So you can see, like I can zoom and show if you want. So you can see a small amount of ST elevation here in lead 2, which I can zoom and see. It's very clear, isn't it? You can really see some amount of ST elevation for sure. I think so. Clear? So in 2, in 3 also you can see. And AVF also you can see a small amount of ST elevation. So this is the AVF here. So AVF also shows some amount of ST elevation here. So definitely there is ST elevation. Apart from that, let me show you what are the other findings that you're seeing. You're seeing a PR depression, TP downsloping along with ST elevation. And in AVR, you will see reciprocal change where you can see the PR is elevated and ST segment is depressed and the TP segment is having upsloping. So this is the classic change of a pericarditis. And very commonly you will be seeing in the inferior and the lateral leads, as I told you. Lateral, you can see small amount of ST elevation is there, some minimal amount, but still this is in the lateral leads. That's what is going to happen. This is a classic acute pericarditis pericarditis, this is not a STEMI. If you see, you will not see reciprocal changes. There is no reciprocal changes. If there are no reciprocal changes, it's unlikely to be a STEMI because there is no injury current. That's why there are no reciprocal changes. If there is an injury current, there will be a reciprocal change for sure. There's no injury current here, so unlikely to have a reciprocal change. Clear? So this is a sign of an acute pericarditis patient. So now we have discussed, right? Acute pericarditis. So stages over. So what is the treatment of acute pericarditis? How will you treat acute pericarditis? You have 3-line treatment. One is the NSAIDs. That the first line treatment, you're going to give analgesics. This will be followed by colchicine, and this will be followed by steroids. So this is staging of treatment. So first NSAIDs, then colchicine, then steroids, depending on what are the indications and the contraindications. So this is how you're going to treat pericarditis, an acute pericarditis. And let us discuss about other types of pericarditis like Dressler syndrome later on. Now I'm just telling entirely about pericarditis. Then you have other differential diagnosis like myocarditis. Myocarditis, what you will be seeing in the ECG. Basically in the ECG, as far as myocarditis is concerned, you'll be seeing most common ECG change will be sinus tachycardia. Like pulmonary embolism, where the most common change is sinus tachycardia, even in myocarditis, the most common change is sinus tachycardia only. Many of the times you'll be seeing non-specific STT changes. Non-specific ST changes, but it may produce ST elevations, ST depressions, T inversions. It can produce anything, myocarditis as well, depending on the amount of injury. And we have to diagnose clinically. Clinically, patient will come with more of a heart failure compared to that of a chest pain, and they will be having history of viral infection most of the times. And most of the myocarditis are viral, and the most common virus to cause myocarditis is parvovirus B19. Clear? So that's the most common virus to produce myocarditis. Previously, it was Coxsackie virus. Now it is no longer Coxsackie virus. It's parvovirus B19 only. So that is the one that is going to cause myocarditis most commonly. And history of viral infection will be there. Some viral-like illness, like flu-like illness will be there. Then patient coming suddenly with heart failure kind of a picture. And you really don't have any clue. Remember, it's closely going to mimic a STEMI or an STEMI because they are producing ST elevation, ST depression, T inversion, all these things. So troponin also can be elevated, which adds on to a confusion because you might be thinking it's STEMI, but if you do a coronary angiogram, you're going to have a normal coronary angiogram because it's a myocarditis, the vessels are normal. But the gold standard for diagnosis is going to be the biopsy. What is the criteria that is used for pathological criteria that is used for biopsying the myocarditis heart? What is the pathological criteria? Yes, that's called a Dallas criteria. Dallas criteria. Clear? Dallas criteria is the one that is typically used for classification of the myocarditis and assessing the severity of the myocarditis through biopsy. Dallas criteria. So apart from that, you can get in many other conditions. Some certain conditions like conditions that produce vasospasm. What are the conditions that produce vasospasm? One is Prince metal angina, of course. So as far as Prince metal angina, they are going to produce ST elevation. There is no specific characteristic of ST elevation here. As far as Prince metal angina is concerned, they will produce ST elevation. And usually patients will be elderly and heavy smokers most of the time. So this will be a big clue. Elderly, heavy smokers. And the patient will have a rapid response to nitrates. Rapid NTG responsiveness. So this will be a big clue in exam again, because rapid NTG responsiveness is not a feature of your acute coronary syndromes. NTG will not be responsive there. So here that might be a very good clue, rapid NTG responsiveness. And remember, the most common vessel that will be involved is right coronary artery, then followed by the left anterior descending or the left circumflex. So right coronary artery is the most common artery involved, and many of the attacks will happen from around 12 a.m. to 8 a.m. because that is the time where the catecholamine levels will be a little high, so that the vessels can be provoked to go for vasospasm. And remember, these are elderly people, these are smokers, and happening in the night doesn't mean, and having a rapid NTG responsiveness doesn't mean we are taught that 70% of people have subclinical infection. So do they have a risk of developing myocarditis? No, only very few people have risk of developing myocarditis. In fact, a lot of virus, even Coxsackie virus, is affecting us in a great deal. So all these things are not going to cause myocarditis. Very few individuals will be developing myocarditis. So leave that. So that's not an issue. Anyways, 12 a.m. to 8 a.m. if it's happened doesn't mean that it's a Prinzmetal metal angina. So there is a strong risk of having an underlying STEMI. So even COVID myocarditis. COVID is a very new disease. We can't really predict and how it is going to work out. So that's why I cannot really comment much on COVID. It's a very new disease, man, COVID myocarditis. But we are seeing a lot of COVID myocarditis, and some young males and young females have already recovered from COVID myocarditis to a large extent. So I don't know the long-term prognosis, but right now it's okay, depending on the clinical scenario again. Anyways, leave that. So as far as the vasospasm is concerned, so first disorder that we are talking is about the Prinzmetal metal angina. And more importantly, one more important point that they are going to give you an exam with regards to Prinzmetal metal angina is a reversible or a transient ST elevation. So I can write here, isn't it? So I was thinking what to write here. So I can write a transient ST elevation. If you find this word, transient ST elevation or a reversible ST elevation, close your eyes and tick on Prinzmetal metal angina. Of course, closing your eyes, you cannot tick in the computer, but anyways, you click that and close then. So that's a transient or a reversible ST elevation. That is what is very classical line. That's a pickup line in exam for Prinzmetal metal angina. So, but of course, the gold standard is going to be a coronary angiogram. Only when you prove the coronary angiogram is normal, then only you can tell the patient is suffering from a Prinzmetal metal angina. But in the coronary angiogram, you can do certain provocation tests and prove the vasospasm. So for example, you can use certain agents like acetylcholine or ergonovin. You can use either acetylcholine or ergonovin, but it's not used nowadays. So acetylcholine or ergonovin can be used as provocation test to induce vasospasm in the coronary vessels if you feel strongly it is a vasospastic angina. Remember the fact that troponins are completely normal here. Normal, or it can be elevated, which means troponins are variable. Depending on the severity of the vasospasm, it can produce either a normal troponin also, or if it's more severe, they can cause cardiac damage and they can elevate the troponin also. So this condition is going to give a tremendous confusion in exam to STEMI. You'll be thinking about a STEMI, but the keywords in exam will be this transient reversible ST elevation, rapid NTG responsiveness, happening typically in the night, midnight. So RCA is affected more than LCA. So RCA territory is affected. So these are the pointers towards a vasospastic angina. That is a Prinzmetal metal angina. As far as the treatment is concerned, you can treat like other anginal these things, but treatment of choice, I know the PG aspirants like this word very much. So it's going to be nitrates because they're going to have excellent responsiveness. But two important problems. What you should not use, that's the question. You should not use aspirin because aspirin can downregulate the prostaglandin I2, that is prostacyclin, so that they can produce more vasospasm. And second is beta blockers, especially non-selective beta blockers. Never use because they can increase the alpha action, unopposed alpha action. Because if you use a non-selective drug, it blocks beta 1, beta 2, there is no beta action at all, only alpha action will be there. So unopposed alpha action can produce more vasoconstriction and they can produce more vasospasm and more trouble. So avoid aspirin and beta blockers. Treatment of choice is nitrates. Then of course, apart from that, you have cocaine poisoning. It's a substance abuse. I'm not going to discuss in detail. Cocaine poisoning or cocaine abuse or a substance abuse. Once again, we don't have any much to say, and usually there'll be young people, but not always. And at the same time, there'll be history of drug abuse will be there. And most of the time in exam, they can give the words like track marks. I think you all will be knowing what you mean by track marks, isn't it? You can get track marks, or probably you can get a word like unkempt. So which means they are always under drug addiction. So unkempt, track marks, that injection marks, drug abuses. That's what we refer to as track marks. And history of drug abuse. All these things will tell you in the presence of this, if you get an ST elevation, likely to be a cocaine poisoning, cocaine intoxication causing vasospasm. Because cocaine is a very powerful sympathomimetic drug because it prevents the reuptake of noradrenaline and increase the concentration of noradrenaline in the synaptic terminal. So their central sympathetic outflow itself will increase to a great extent. The peripheral sympathetic surge will be there. That can be the reason for vasospasm. And once again, you have to prove this by coronary angiogram. It has to be normal, because cocaine people also can get MI, isn't it? It's not like they will always go for only cocaine related problems. They can get an MI. So better in doubt, always take for coronary angiogram and prove that it is normal, because it's vasospasm, and troponin will be normal or increased depending on the degree of cardiac damage. So that is absolutely variable. Then we have discussed on the vasospasm. Fifth one is very special, that is Takotsubo cardiomyopathy. So everyone, the moment I tell Takotsubo cardiomyopathy, you should be able to tell easily. So what do you mean by Takotsubo cardiomyopathy? Yeah, broken heart. Avinash is putting symbol also for the broken heart. So Takotsubo cardiomyopathy is basically due to sudden emotions, very common in females. I mean, if you want to know the clinical background, let me tell the clinical background there. Clinical background, you should be usually a female, elderly, very common after 50 years. Usually there will be history of some sudden emotion, followed by they will get chest pain, some heart failure also may be there, or predominantly heart failure also may be there, so that's not an issue. And ECG will show ST elevation, of course, and you cannot differentiate any characteristic feature. Contraction band necrosis. Contraction band necrosis can happen in any myocardial infarction. That's a histological finding. Why suddenly now, Amiya Ranjan? So such chest pain and or heart failure, they're going to come. And if you take the troponins may be normal or can be increased, doesn't matter. Again, it's variable depending on the severity. And what's going to happen is during this sudden emotion, once again, you're going to get a vasospasm, sudden vasospasm. But more importantly, yes, that's a very, very good question, Ishan. That's what I'm going to tell. So they're going to affect the distal LAD more. Distal LAD is the most common area to go for vasospasm due to unknown reasons. So if the distal LAD goes for vasospasm, what is actually supplying the distal? I mean, distal LAD is supplying which area? Which area of the heart? Of course, LAD is supplying the left ventricle. So which area of the left ventricle is supplied by distal LAD? Apex, of course. So the apex will go for stunning. I'll tell you what I mean by myocardial stunning. The apex will go for stunning. Suddenly, it's like a blow. For example, if somebody hits hard on your head, what will happen? You'll go and fall down and you will be unconscious, knocked out for a variable period of time. It can kill you also, but you'll be unconscious for a variable period of time. Till that time, you don't know what's happening, but still you will be breathing, you'll be alive. It's like myocardium is also like that. Sudden ischemia like this will make the myocardium go for stunning, which means they'll be knocked out. In the sense like they will go for unconscious state, which means they will not do their function. That is, they will not contract and they will become dilated. And over a period of time, once everything is getting better, they will recover. So this is what we refer to as a myocardial stunning. It's an alive myocardium, but it's not doing its function. It will be a dilated myocardium. So which means you're going to have an apical dilatation. And this is what we refer to as something called apical ballooning. That's classical Takotsubo, and that's why it's also referred to as an apical ballooning syndrome, or otherwise referred to as something called a broken heart syndrome. So this can be found in the echocardiogram, or probably you can find this in the left ventriculography also. Even though we don't do ventriculographies that often, but in the ventriculography is the place where you can see very, very nicely. That's left ventriculography can show apical ballooning, and the patients might show this finding in the echo itself. Let me recap. So patient coming with chest pain, ST elevation, troponin elevated, apical ballooning. What will you diagnose? What will you diagnose? What will you diagnose? Am I audible? Yeah, of course I'm audible. What will you diagnose, man? Patient coming with chest pain, ST elevation, apical balloon, echocardiogram. Yeah, Shikar is also telling broken heart. See, only one person has told correctly. In this condition, my first diagnosis will be still STEMI. STEMI is the first diagnosis here. I won't diagnose. Why can't it be a distal LAD lesion? Why can't be a distal LAD thrombus? Sometimes it could have autolyzed also, or distal LAD is there which could have caused all this problem. So sometimes there can be autolysis of the thrombus. Why it can't be a STEMI? It can be a STEMI. So my first priority is still a STEMI. And if you want to rule out a STEMI, only one way is there. Nothing else can rule out except the coronary angiogram. So that is why in this setting, definitely I have to do a coronary angiogram and prove the coronary angiogram is normal. And I have to prove that the patient is having a clean coronary or a normal coronary. Yeah, apical ballooning can be there. Why can't it be there? It can be there. So that's why I'm telling. So what happens in Takotsubo? Suddenly you have a vasospasm. So the myocardium goes for stunning. That's why it is ballooning out, because it's not doing its function properly. It's not having sufficient contraction now. So same thing I'm telling. If it's a thrombus occluding, so let it get autolyzed and now the blood perfusion is okay. So still it's going to show some similar picture only. So the first diagnosis is still STEMI. So I have to rule out there. In exam, if they give all this in AIIMS, it's fine. But in real time, do you have real guts? That's what I'm telling. If it happens to one of our relatives, ST elevation is there, echo shows ballooning, and you have an history of emotion, and patient is already elderly, more than 50 years prone for STEMI, will you take it as a Takotsubo and you will defer a coronary angiogram? Definitely no. We are not going to do that. We are going to think about STEMI only. Practically speaking, it's a STEMI for me, because the amount of STEMI cases I'm going to see per day will be more than the amount of Takotsubo cardiomyopathies I'm going to see in the entire life. So that's how the nature is. So definitely don't diagnose this in real time. So in exam, if they give apical ballooning, then fine. You can really diagnose a Takotsubo cardiomyopathy, not a problem. So of course, one important point that you have to note here is the treatment part is very important as far as Takotsubo cardiomyopathy is concerned. As far as the treatment is concerned, you need to really think about not giving any adrenergic drugs, which means dobutamine, dopamine, noradrenaline. All these drugs are contraindicated because they are more sympathomimetic and they're going to really cause more trouble to the patient. So you should not really give. So of course, the treatment of choice is going to be the nitrates, plus or minus a little bit of benzodiazepines will do. Even for cocaine poisoning, benzodiazepines will do, because cocaine poisoning patients will be extremely agitated because of that hyperactivity that it creates. So benzodiazepines will be useful in cocaine poisoning also, but here also benzodiazepines will be useful because really here the patient will be very anxious, and so it might be having a role. So nitrates are the again standard treatment here, plus you're going to use a standard heart failure therapy. So generally, as far as the many trials are concerned, mortality is very low, less than 1%. But once upon a time, AIIMS gave one question. Like they gave, patient came with 54-year-old man came with sudden emotion. He had apical ballooning in echocardiogram and the patient died. So he had ST elevation in the ECG. So what is the diagnosis? And in that STEMI was not there, and the answer was Takotsubo cardiomyopathy only. And a lot of students started asking me, sir, AIIMS question told that the patient died immediately. You told mortality is less than 1%. How is it possible? See, AIIMS is not the gold standard. First, understand that. So they are also humans, and they would have seen a case of Takotsubo cardiomyopathy who have died probably, or that could be a STEMI, but was not in the options anyways. So don't argue these kind of silly things and all. Very, very small things. Mortality is still, very less. They're going to do very well. So mortality is less than 1%. What else can be used to maintain the contractility of the heart? Remember, depending on the type of heart failure that you're doing with. So remember, heart failure, if it's producing hypotension, then in that scenario, you're going to use some different kind of a drugs. If heart failure is having a normal BP, then you're going to use a different kind of a drug. Most of the times in Takotsubo, they won't decompensate. You're going to use no drugs, in fact. So if there is a congestion, I'll be using diuretics, and the nitrates are more than enough to reduce the preload. So I'll be managing in that way only, depending on how the patient is. The patient is crashing, having a low BP. Now I don't care about dobutamine in that setting. I'll be really giving, dobutamine cannot be given in low BP, first of all. You can give dopamine or probably even noradrenaline in that setting. So remember, we are talking about a relative purpose for the sake of exams. That's all. So where that point becomes really important, where whenever the patient is having heart failure with normal BP, you tend to start with dobutamine. Because dobutamine is a very good drug for heart failure with normal blood pressure. That's why I told you that point. But if the patient is crashing, then that's different. So you have to use other drugs like dopamine and all this stuff. So there is no point in revolving around that. So Takotsubo cardiomyopathy, we know that. So what is Takotsubo cardiomyopathy? It's a broken heart syndrome. So I think what is the number of ST elevation we are seeing? Sixth one. Sixth cause of ST elevation. So what is the sixth cause? Sixth cause of ST elevation is Brugada syndrome. I'll be discussing in detail about Brugada syndrome. You know, there's a pseudo RBB will be there in the ECG. Along with that, you will have an ST elevation in leads V1, V2, plus or minus V3. So this is classic Brugada. And of course, clinically, the patient will be coming with syncope or probably a ventricular tachyarrhythmia like VT or VF. And there is a family history of sudden death, especially family history of sudden death will be there. And most of the times, the death happens very quietly. That's very important. So they happen at rest or sleep. This is a very big clue in exam. So whenever the examiner tells death happens at rest or sleep, Brugada. That's all. I mean, a lot of differential diagnoses are there, but examiner usually wants the diagnosis of Brugada there. That's all. And usually diagnosis is made by ECG and your electrophysiological studies. And your electrophysiological studies shows the development of malignant arrhythmias. Treatment of choice is going to be the implantable cardioverter defibrillator because the day of ventricular tachyarrhythmia. So you have to give a ICD for these guys. So this is some short view about Brugada. They can produce ST elevation. Then you have left ventricular aneurysm. They have different types of left ventricular aneurysm like pseudo aneurysm and true aneurysm. But let us talk about a true aneurysm here. So we'll leave the pseudo aneurysm. Pseudo aneurysm is different. That's a deadly diagnosis. But let us talk about true aneurysm here. OSA also can cause death in sleep. I don't know. I have not seen OSA patients dying suddenly in sleep. If they are choking, you are thinking like they will swallow the tongue and they will choke. I really don't know. I mean, to cause that much amount of OSA, it's the family's problem not bringing the patient to the hospital faster. So which means till the time of death, if they're going means it's very bad. So usually they don't cause. Central apnea may cause. But we have a lot of overriding mechanisms. Remember, death is not that easy. And our body has an extraordinary capacity to fight against things, fight against odds. And I've seen that in many patients. Expand ICD, implantable cardioverter defibrillator. Clear, it's a mobile defibrillator. The patient carries within them all the time. So which means it will be implanted in the chest. So which can give a shock whenever the patient needs it. Whenever they go for tachyarrhythmia, they give a shock and they revert it, patient gets better. So that's why the treatment of choice. So you're talking about a true aneurysm. So true aneurysm, typically the clinical background is very important. Whenever you think about an LV aneurysm, the patient would have had a history of STEMI only, not an NSTEMI. That's very important because it's a complication of a transmural infarction. Only get a transmural infarction, that area will get weakened and they'll outpouch as a aneurysm. Suppose if the patient is having a subendocardial ischemia and infarction, the outer wall is still strong and they cannot form an aneurysm. So only STEMI, it's an exclusive complication of a STEMI. Only STEMI can cause LV aneurysm, not NSTEMI. And more importantly, if the examiner gives you something called a persistent ST elevation, that's the key here. If the examiner gives persistent ST elevation, what do you mean by persistent elevation? Even after 3 weeks from the time of STEMI, which was treated, and it's an old MI, and this has been treatment done, and there is pathological QAs that have formed already, which suggests that area is dead, and at the same time, currently the patient will be asymptomatic. So treatment done, pathological QAs in the ECG have come, but the patient is asymptomatic. Still, you have a persistent ST elevation beyond 3 weeks. Then that's probably a sign of a left ventricular aneurysm. So in exam, look for the word persistent ST segment elevation, even after successfully treating a STEMI, and it's now 3 weeks. At least till the patient is showing ST elevation. Very, very important sign of a LV aneurysm. So diagnosis will be done by echocardiogram. So echocardiogram can easily find out. So you have neck-based diagnosis. Usually this will have a broad-based neck, and you have a narrow-based neck also, which can be seen in a pseudoaneurysm, which is even more deadly, which we'll be discussing subsequently in the complications of myocardial infarction. So echo can give a very good idea. And the neck of the aneurysm is really important to find out whether it's a true aneurysm or a pseudoaneurysm. But anyways, echo can make a diagnosis easily here. And treatment is nothing, it's only conservative. So if you need, you can do a surgery if you feel it's a high risk and it can cause a rupture. But apart from that, you don't really and need a surgery if you think it will stabilize over a period of time. You can do surgery if you want. Yeah, always ST elevation of LV aneurysm will be having a Q wave. Yes, because it's a completed infarct, because it's a dead myocardium in that area. So there will be a Q wave. Correct only what you're telling. And there are multiple other causes also. What other causes we have that can produce ST elevation? So let us go for the other causes. Now I think we have covered almost everything. So what are the other causes that can produce ST elevation? So we have ERS, early reported syndrome, that is benign early reported syndrome. So ERS is very simple. So most of the time the clinical picture again is very important as far as ERS is concerned. So if you talk about an early reported syndrome, a lot of reasons are there for this thing. Let us finish off this. I'll come back to that later on. So as far as early reported syndrome is concerned, the clinical picture, the patient will come in a completely asymptomatic fashion for another disease, like probably a GRD. For some other reason, you will come to the ER and you will take ECG and you will find incidental ST elevation. Asymptomatic patient, you are finding an incidental ST elevation. That is the key feature of benign early reported syndrome. So what will the ECG show? ECG will show typically an ST elevation. It will be a very small ST elevation. And more importantly, I didn't draw that, isn't it? So, my God. So more importantly, you will have something called a fish-hook appearance. So that's characteristic. So this is the key here. So this point, this is what the small notch I drawn here. So at the J point. So that's something in ERS we call it as a fish-hook. And it's a type of a J wave only. And the most common location where you see this is in the V4. V4 is the most common location. Most commonly you will see in the V4. You see in the V4 this kind of small fish-hook kind of an appearance. That is something suggestive of a benign early reportation syndrome. And you don't really need any treatment. But remember, that is on Sweden study. In one family they approved if this ERS is seen in inferior leads, 2-3 AVF. Precordial leads, it's extremely common and it's likely to be benign. But if you see in inferior leads, there is a risk of sudden death. That's what they have told, but I'm not very, very sure about that. Because that is proved only in the Northern Europe families, but in India, I don't know how much it's relevant. But that small point that you have, but in general, we don't give any treatment for that. It's considered to be a benign condition, early reported syndrome. Then apart from that, you have many other conditions as well. For example, left ventricular hypertrophy itself can produce ST elevation. So which kind of LVH will produce? It will volume overload will produce ST elevation or pressure overload will produce ST elevation. Can anyone tell which kind of LVH will produce ST elevation? Volume overload ventricle or pressure overload ventricle? Of course, volume overload is going to produce ST elevation. Remember, pressure overloaded left ventricle will be stronger, more thicker, and they will compress, producing more subendocardial ischemia, producing ST depression and T wave inversion. Clear? They'll produce more of a ST depression and T wave inversion. So that is suggestive of a subendocardial ischemia. That is seen in pressure overload. So volume overload is the one that's going to produce predominantly ST elevation in this setting. So once again, you will be seeing more in the V5, V6 area because this kind of ST elevations will have a bigger complex and you'll have a little bit of ST elevation, and this kind of ST elevation will be seen more in the V5, V6 zone, which is basically the left ventricular zone, that V5, V6 you're talking about. Probably sometimes in the 1 AVL you can see, but very, very small amount of ST elevation. It will not be usually significant. And clinically, the patient can have any, clinical picture that has volume overload. Like for example, they can have a mitral regurgitation. They might have a ventricular septal defect. So for example, they'll have history of background MR. They might have history of background ventricular septal defect, which typically produces volume overload to the left ventricle. And treatment is aimed at the underlying cause. Underlying cause is going to be the treatment. That's all. And then we have, what else? You have left bundle branch block. Left bundle branch block can produce definite ST elevation. We know that, I told you, and there will be a discordance. We have discussed this multiple times in the past. So for example, if you have the early precordial leads, in early precordial leads, this is very characteristic because in early precordial leads in LBUB, you will get negative deflection. We know that it's a QS complex in V1, for example. and they can produce discordance. And once they are producing discordance, you can see a sort of ST elevation. If you take this is the J point, even if you take this is the J point, at 80 milliseconds from the J point, there will be some elevation will be there. So which means the ST elevation is a very common feature in the setting of a left bundle branch block. So that is why the importance here is not this. The importance here is how to diagnose myocardial infarction, especially a STEMI. We're talking about a STEMI in the presence of left bundle branch block. So this is what is going to be important. So for this, we have something called a Scarbosa criteria. We have something called as Scarbosa criteria. That's how we find out what Scarbosa criteria tells. So very simple. Let me come back to the image of LBB because we need to know LBB now. Where is that? Where is that? Yes, got it. So this is LBB basically. In left bundle branch block, you have this kind of stuff, and this is a J point. And from the J point, if you see from 80 milliseconds, so definitely there's some ST elevation is there for sure. There's no doubt about that. And mostly you will have a discordance. So especially in the leads that are showing negative, they'll have a positive T wave. In the leads that they're showing positive QRS, they'll have a negative T wave. And we know very well that this is what we refer to as something called a discordance. Scarbosa criteria is very, very valuable, especially when you have a concordance. When you have a concordance. So what do you mean by concordance? Which means that discordance is lost. So number one. So if you lose that discordance and you develop concordance, which means especially this is concordance is very, very important, especially in leads with positive QRS complex. So in leads with positive QRS complex, it has the highest value. So for example, you have a positive QRS complex here in V1, V5, and positive QRS complex in lead 1. And of course, the T wave should be negative here. It should be inverted. That's a discordance. Suppose in case if there is a positive T wave here. So this is what we refer to as a concordance. If you have a positive QRS with a positive T wave, like this. So this is considered to be a definite sign of a myocardial infarction. And the same concordance can be applied to the leads with negative QRS also. For example, if you see this in negative QRS, this has a little less value, but still it is important. For example, if you see in V2, you are having a negative QRS and then you're having a positive T wave. But if you have a negative T wave also here, so this is negative, negative becomes a concordance. So this kind of concordance once again is a sign of a myocardial infarction. Clear? So concordance should not be there. Our third point, what Scarbosa criteria tells is excessive discordance. For example, there is a limit on how much ST elevation you can produce. For example, if you have this thing J point and there is a limit on how much ST elevation you can produce. Suppose if you have a too much of discordance, for example, if LBB is going to produce this much of ST elevation, now if you are having this much of ST elevation, so there's a limit, isn't it? How much ST elevation it can produce. So here it is this much ST elevation. So this is not really correct. So if you have an excessive discordance, then once again it's a Scarbosa. I mean, it's considered to be Scarbosa positivity. So these are the basis of Scarbosa criteria. Let us go back to the image and I mean some ECG and see what do you really mean by Scarbosa criteria. Where I've kept this Scarbosa. I don't know. I had this Scarbosa, but I don't know where I've kept it. Okay, I think I can show tomorrow. I think I've given it, but I don't know where was that. Okay. Okay, fine. So don't want to waste time on this. Okay, so that's the Scarbosa criteria. So Scarbosa criteria is going to basically revolve on certain things. So suppose in LBB you should have a discordance. Suppose if you have a concordance, which means T and QRS in the same direction. So especially in leads that are showing positive QRS, if you see concordance, that has a very high value. In leads which are having negative QRS, if you see a concordance, it still has a value, but not that great value. And second is discordance. Discordance is a normal phenomenon, but Scarbosa criteria tells extreme discordance is also a problem, which means extreme discordance is defined as if the elevations or difference are more than 5 millimeter. So that's extreme discordance. So which means discordance should be, there is a limit for discordance, how much ST elevation they can produce. If there's an extreme discordance producing more than 5 millimeter of elevations or depressions, then this can be taken, but what is the value for this? We don't know. So query value, whether this has a great value or not, we have no idea. Many studies have failed to prove sufficient value for this, but every study have clearly told that this is going to have a huge value, especially in a leads with positive QRS. So this is what we refer to as something called a Scarbosa criteria. So do you understand Scarbosa criteria? It is given by someone called Elena Scarbosa. Yes, it's quite simple, man. Clear? It's about concordance versus extreme discordance. That's all. Concordance is absolutely, like diagnostic, especially in the leads with positive QRS. Excessive discordance or extreme discordance is also going to be a problem. So this is Scarbosa criteria. Then there are some other two signs that you have to know the name. How can you find old infarction? I'll show you the images tomorrow because I think I forgot to push this out. So old infarction in the presence of left bundle branch block. How you can find whether the patient had an old infarction in the presence of a left bundle branch block. I think I have the image. I'll just check in my phone once. Yes, I have it. There are two signs. Can anyone tell what are the two signs? Can anyone tell what are the two signs, basically? Old infarction. So one is called a Chapman sign, and the second one is called Cabrera sign. Cabrera sign and Chapman sign. Yes. So what is this basically? I'll add drop. So you have Chapman sign and Cabrera sign. So this is the notch that is seen. You can see the arrow that is pointing there. So that's a notch that you're seeing in the upslope of the S wave. So if you have a notch in the upslope of the S wave, this is what we refer to as a Cabrera sign. So then this is a classic example of a Chapman sign. So what you mean by Chapman sign, basically, it's in the notch in the upslope of the R wave. So if you're seeing in the R wave, that is a Chapman sign. So I think in the positive leads you can see. So this area in AVL and probably in lead 1 you can see, in lead AVL you can see. There is a notch in the upsloping of the R wave. So that is what we refer to as a Chapman sign. Clear? Typically this is seen in lead 1 AVL, V5 and V6. Clear? So because that is the area where you're going to see positive waves in an LBB. In LBB, 1 AVL, V5, V6, as we told, it should be a monophasic R without any septal Q. So there only you're going to see a monophasic R. If you see notching in the upsloping of the R, then that indicates that the patient is having a Chapman sign. On the other hand, if you see this kind of notching in the upsloping of the S wave, typically in V2, V3, and V4, that's the mid precordial leads, that is suggested as something called a Cabrera sign. So let me write here what do you mean by Cabrera sign. V2, V3, V4, notching in the upslope of S wave. Similarly, in 1 AVL, V5, V6, where you have to see a monophasic R wave in left bundle branch block, if you see notching of R wave, that is upslope of R wave. So that is Chapman sign. So we know what is Cabrera sign and we know what is Chapman sign. So this is how we identify old infarction in a patient who is already having a left bundle branch block. And this was me already, isn't it? Clear? Are you understanding this? I didn't have the Scarbosa criteria only. I'll get it tomorrow. I don't know where it is there. I'll just check once. Just hold on. I must be having at least one image. Okay, fine. No issues. I'll show you tomorrow. Scarbosa criteria. Fine. So we now have diagnosed the left bundle branch block also. Clear? So this is very important. That's why I want to tell that left bundle branch block. So what are the other causes? Some trivial causes of ST elevation is also there. What are the other causes that can produce ST elevation? Of course, you have to remember LV pacing. Sorry, not LV pacing, RV pacing, pacing apparatus. If you have an RV pacing, they're going to show an LVBB morphology, so they can produce ST elevations. And ventricular ectopics can show ST elevation because they produce LBB morphology. Then yes, hypothermia. Because why hypothermia? Because they produce something called Osborn waves. Because of that, you might appear like the patient is having ST elevation. And intracranial problems, intracranial issues like intracranial hemorrhage and all these things. Remember, intracranial problems can produce ST elevation as well as ST depressions as well as T wave inversions. So these are called as cranial T waves. Whenever you have a deep T wave inversion because of a subarachnoid hemorrhage, that has a special name called cranial T waves. So a lot of intracranial problems have some effect on the heart. So ventricular ectopics can produce, as I told you, a bizarre thing like ventricular ectopics is hyperkalemia. So hyperkalemia also can produce ST elevation, to be honest. And more importantly, one more entity is there that is called post DC shock, post DC cardioversion. After giving a shock, you might have a ST elevation. Remember, this will be usually only transient ST elevation, and it will be lasting for less than 5 to 10 minutes. It will not last for more than 5 to 10 minutes. And that is why, especially we are working in emergency department, when the patient is coming in cardiac arrest and you see a VF, and if you shock them, immediately after the rhythm is reverted and the patient gets okay, I mean, at least the patient gets his BP back and pulse back. So in that scenario, you can see short-term ST elevation in the ECG. So that does not really mean that the patient is having a STEMI. You have to wait for 5 to 10 minutes, which means if it's a shock-induced ST elevation, then it will resolve within 5 to 10 minutes. If it's going to be a STEMI, then the ST elevations will persist. And in that setting, you can imagine that the reason for shock is the STEMI that the patient is having. So again, you have to be very clear in that. So just seeing a ST elevation immediately after a shock, you should not think like the patient has got a STEMI and activate the cath lab. Wait for 5 to 10 minutes. ST elevations will usually settle after 5 to 10 minutes if the patient is having a shock-related ST elevation. Clear? So you can get in hypercalcemia, because hypercalcemia also can produce Osborn waves like hypothermia. Then you can get in lead malpositions. If you have malposition, they lead to a different area. So in that setting also you can get a ST elevation. Fine. So these are the causes. I mean, the most important causes I've explained in detail, step by step, in the entire, like this ST elevation related thing. I've given a lot of clinical ideas also, which will be very useful for your exams, especially when answering clinical kind of a question. That's why I told you in a table form so that you can revise easily later on. So acute STEMI, how it will behave, pericarditis, myocarditis, vasospastic conditions, Takotsubo cardiomyopathy, Brugada, aneurysm, then ERS, LVH, LBB, including the Scarbosa criteria, all these things are important. It's not really important, the other causes which I have told you, that RV pacing and all, even though this DC cardioversion may be practically important thing. So that's why it might be a little important. Clear? So if you have understood the ST elevation, then I'll tell you the cause of ST depression, maybe. Do you understand? Most of them are sleeping, I think. Do you understand? Yes, that's all. So these are differential diagnosis for ST elevation. Okay. So ST elevation, fine. So then we have something called ST depression. Clear? So ST depression, as I told you, ST depression also has a lot of causes. Carbosa criteria to be explained again. How many times? When from morning I'm telling, will arrhythmias be covered today? I don't think it's possible. I'll try to do as much as possible because these are also very important. Because a lot of clinical things also I'm covering here because tomorrow my things will be much easier. Anyways, let us move on to the ST depression now. Recording will be uploaded in this app or not? Yes, we are actually planning to upload the recordings in the app only, in the same app only. I think they have started the process. We have been doing for a while because it's taking a huge memory. So they're compiling and adding. I think tonight they will add. Cause of persistent elevation in ST elevation. ST LV aneurysm. That is because again of the injury current, but it will travel in a from a different area, which will, that's not really important. I'll discuss you about that because when I'm going to discuss about the STEMI part, because there are two types of aneurysm which you have to distinguish: pseudo and true aneurysm. So as far as ST depression is concerned, so you have many causes. So the first one you need to think of is about the subendocardial ischemia or an infarct. Subendocardial ischemia or an infarct really can produce ST segment depression, so not a big deal. And at the same time, you can get in chamber hypertrophies, especially in left ventricular hypertrophy, in right ventricular hypertrophy, you can get ST segment depression. And more importantly, this kind of ST segment depression will happen in a pressure overloaded ventricle, not a volume overloaded ventricle. That's very important. So for example, in LVH, typically in V5, V6, most of the times I'm telling V5, V6, 1 AVL is the lead that directly sees the left ventricle. So that's on the left side. So you might see something like this. So which means you will be seeing ST depression along with the T wave inversion also will be there. So this is very characteristic, ST depression and T wave inversion. This will be there, this kind of ST depression and T wave inversion. That's very characteristic of left ventricular hypertrophy. Right ventricular hypertrophy can produce similar kind of ST depression in the early leads. For example, V1, V2, V3 may show ST depression, T wave inversion in the setting of right ventricular hypertrophy and associated strain. So that's where you're going to see. Apart from LVH and RVH, you can get ST depressions in left bundle branch block. You can get ST depressions in right bundle branch block. So that is due to aberrant repolarization. We know that LBB may not only cause ST elevation because if it's discordant, if it's a positive QRS, then there will be a negative T wave, so that you might have an associated ST depression in that setting. Then of course I told you myocarditis can produce myocardial damage. Last time itself we have discussed myocarditis can produce a variety of changes. And of course, pulmonary embolism is a very important entity. In pulmonary embolism, why you get T wave inversions? That is because the right ventricular strain. Because they produce right ventricular strain, typically they will have ST elevation, ST depressions, T wave inversions in V1 to V4 most of the times. You might get right ventricular strain in pulmonary embolism. Because of that, they can go for ischemia and they can develop ST depressions. And hypokalemia can produce ST depressions. Very, very important for exams. We'll see the strain means what? Strain means strain on the heart. I don't know how to tell, like some sort of strain that is created on the wall. So for example, you are trying to tear something, you create a strain on that particular substance. It's like myocardium is stretched and it's not able to stretch, you create a strain on the myocardium. So hypokalemia, Shikar is telling, I think I have to borrow words from you guys only. Tension. Physics, okay. So hypokalemia. Hypokalemia can produce ST depression. We know that. One of the important signs of hypokalemia is ST depression. Then digitalis, digoxin can produce ST depression. We know what is digitalis effect. And it's going to produce a typical type of, this is not correct. So typical type of ST segment depression called as hockey stick appearance. Even though it's not correct, I'll describe how it happens. That's called a hockey stick appearance or a reverse hockey stick or whatever you tell. I don't really care. This looks like a hockey stick for me. If you think it's a reverse hockey stick, that's fine. So they're putting a hockey stick kind of ST depressions, and that's otherwise referred to as something called a Salvador Dali mustache appearance. Yes, correct. Deepika has told already. Salvador Dali mustache appearance. I'll show you that, where we will discuss with regards to it. So we have I think this is the these are all special waves. I want to show the digital. Where is the digitalis effect? I think I have forgotten to add that also. 1 second. Okay. Yeah, I think we got it. So this is a typical digitalis effect where you can see, I mean, you can concentrate on the 2, 3 and AVF basically. So if you see 2, 3 and AVF, you can see this kind of hockey stick kind of ST depression. So that is actually digitalis effect. Why I want to tell really about the digitalis effect here is many students do confuse this with the digitalis toxicity rather than digitalis effect. Remember these kind of ST segment depressions, if you see that kind of hockey stick depressions, that is just a digitalis effect. That cannot be a digitalis toxicity. And that's really, really important to understand. And very, very important. That's digitalis toxicity only. That is not digitalis effect to be in the first place. We're going to tell this ECG. What is this one? Now gotcha. What is this one? You are going to answer. What is this one, basically? What has been shown here? Where is the tick? What is the tick here? I really don't know. This is not by Gemini. Okay, let me come back to that. I'll try to add something. I can add or not? No, I can't. So actually here I'm trying to show something called a Scarbosa criteria, man. That's what I'm trying to show here. This is basically a Scarbosa criteria. So what you're seeing in V1, can you type and tell what you're seeing in V1? What are you seeing in V1? Left bundle branch block. All right. That's fine. So you're seeing a V1. I mean, there's a little bit of white QRS, and you're seeing loss of discordance. Where is loss of discordance there in V1? I don't think so. I mean, this is a normal discordance only. You are seeing a negative QRS complex with a positive T wave in lead V1. So this is absolutely okay. So that's the left bundle branch block that you're seeing. That's all. That's what I wanted the diagnosis. And the left bundle branch block can be further confirmed by seeing V6 also. As I told you, in V6, you are having a positive QRS with a negative deflection. Once again, there is no problem here. So this is a normal discordance. This is a normal discordance. But what are you seeing in AVL? What are you seeing in AVL? Concordance. So what do you mean by concordance? You have the QRS. Yes. So you see a QRS in the same direction and the T wave also in the same direction. So of course it's going to be a concordance. So definitely this must be a STEMI in the setting of a left bundle branch block. So this is how Sgarbossa criteria makes sense. So now you can understand. So here there is no Sgarbossa criteria is not really positive here. And in lead V1 not so good. And as far as the AVL is concerned, it's a definite Sgarbossa positive. As I told you, extreme discordance, I'll show you a different. No, it's not extreme discordance. I don't think. Yeah, only 3 millimeters there. There's no extreme discordance, but this is a concordance. So remember, as I told you multiple times, you should not think about excessive discordance unless and until there is no concordance. So if there is a concordance, that makes the most important information because we know that. So concordance is equal to STEMI. That has the highest value, especially as I told you before, in the leads that are showing positive QRS. If you have a concordance, that has the highest value as per the Sgarbossa criteria. So don't really think much about it. So digoxin effect, as I told you in the previous digoxin effect means you are going to have this kind of hockey stick ST depressions, or otherwise referred to as something called a Salvador-Dali moustache appearance. I'll come up with a better image tomorrow. I want to put in the PowerPoint, that's why. So Salvador-Dali moustache appearance, that is digoxin effect basically. And apart from that, many other conditions can produce, tachycardia can produce, exercise can produce. These are physiological situations. Fever can produce. So many other conditions. Fever, sepsis can produce. Severe anemia can produce ST depressions. Hyperventilation can produce ST depressions. Acidosis can produce ST depressions. So many conditions are there which can produce ST depressions. But I don't think it's that important. So what is more important is the hypokalemia related ST depression. That's definite question in the exam because one of the important hypokalemia related changes is different. Then digoxin effect, that particular hockey stick, Salvador-Dali moustache appearance of ST depression, very, very important. Then bundle branch blocks, maybe, and the pressure overloaded ventricle, maybe, and more importantly, it's a subendocardial ischemia and an infarct. So that's going to be the most important. So whatever I've ticked in green here, so that are going to be the most important causes as far as exams are concerned. But please don't forget hypokalemia. Hypokalemia is a very important cause for ST segment depression. So now we have discussed in detail with regards to the ST segment. Then we have our T wave to be discussed, isn't it? I think I'll come back to the T wave. So T wave is simple. It's going to complete very fast. Let me give it in green. So this is the T wave. We know that. T wave. So T waves, there are many different things about T waves. T waves can be flat. So T waves can be very tall, unusually tall, or T waves can be inverted. So that's called T wave inversions. Or T waves can be coming in alternative amplitudes. So positive T wave, negative T wave, positive T wave, negative T wave, or a bigger T wave, smaller T wave, bigger T wave, small T wave. So this is what we refer to as a T wave alternates. How to differentiate a P wave under T wave normally? I mean, this is a very basic question from every beginner. I think you must not be so well versed about these days. That's why. Remember, again, the same electrophysiological rule applies. If a wave is originating from one particular area, and consistently if it's originating from that area, it will have the same morphology. So it's the morphology that will differentiate. Basically, you cannot really differentiate based on just by seeing. The morphology is what will tell you. If it's coming in the same time, same area, then that can be considered as that particular wave unless proved otherwise. For example, because this is a very basic question. Somebody is asking, how do you find out it's a T wave or a P wave? For example, somebody wants to, suppose if I want to take an ECG, let me take an ECG here. What ECG to get confused? Okay, this is the best ECG to get confused. Okay, I'm going to discuss in this only. So what Indra is asking is P wave and T wave, how will you differentiate between them? So to add your confusion, this is the best ECG. Remember, there are two waves here. So you don't know really. So there is another wave here. So what is this wave? What is this wave? And what is this wave? So I'm telling, so I mean, it's my usual assumption that this is a QRS complex. And after the QRS complex, there should be the T wave. And that should be the T wave, of course. And this wave, I'm confused whether it's a U wave. And this wave, I'm very sure it's a P wave because it's coming before the QRS complex. So this must also be the P wave. But what I'm trying to tell is, before commenting that it's a U wave, first see the morphology. See this wave's morphology, and see this wave's morphology, and see this wave's morphology, and see this wave's morphology. Is there any difference in the morphologies between them? They're looking the same, or is there any difference? I don't think any difference is there. See, remember, if the morphologies are the same, it cannot be coming from a different area. It has to, by electrophysiological principle, it has to be from the similar area only. So all these are basically P waves only. It's a Mobitz 2 block. That's why they are having excessive P waves. So that's why I'm telling you, like it's all about the morphology and a little bit of common sense and some clinical information. If you add all together, you might become an expert. That's simple. That's all. So you cannot really confuse this with the U wave at all, because U wave will definitely, if it is the case, it will be definitely, it will be of different morphology because the origin is different and the mechanisms of generation is different. It cannot have the same morphology of another wave, unless in exceptionally rare cases where you can publish in certain journals, if you get that kind of a thing. So what are other areas where you can confuse you, whether it's a T wave or a P wave? This is the digoxin ECG, man. Actually, I have it, but I don't know. I mean, this is the same ECG I wanted to show you. I think I have it. I just forgot it. So this is the digoxin ECG that we wanted to discuss, where you can see this kind of hockey stick ST depressions. So this is an inverted hockey stick or whatever hockey stick depression you are seeing. So this is the hockey stick ST depression that you are seeing. So this, especially if you see in the inferior leads 2, 3, and AVF, very characteristic for digoxin effect, not digoxin toxicity. Definitely, you have to write it in bolden words. It's not toxicity. It is just effect, digoxin effect. Any patient who's taking digoxin may get this kind of hockey stick depressions. Can you find out a P wave in this rhythm? Can you find out a P wave in this rhythm? Looks same as LV strain. I'll show you LV strain in some time. This is not LV strain. And LV strain, you're going to have more in the V5, V6 only, and probably in 1 AVL. Why the hell you should have in the 2, 3 AVF? See, you can substantiate very easily. ECG is something which can be argued easily. And it's something, it just needs some kind of exposure, that's all. It's very easy to find out. I mean, anyone found the P wave in this ECG? Anyone found the P wave? Yes, where is the P wave? Show me. I don't know. I couldn't find. So where is the P wave? 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 I don't think this ECG is having a P wave. So there is no P wave in this ECG. No P wave in this ECG. Block in SA node. That's what Pradeep is telling. But before that, see the gap between these two QRS complex and see the gap between these QRS complex. What is the RR interval here and what is the RR interval here? It is variable or it is fixed? It's variable or it's the same? It's variable, right? So it's an irregular rhythm having no P wave is equal to atrial fibrillation. This patient is actually suffering from an atrial fibrillation. Why I'm showing suddenly atrial fibrillation here? Because this is the place where you use digoxin extremely commonly, and that's why it has caused a digoxin effect. Why use digoxin here? That is to reduce the rate of the ventricular response. The patient would have been coming at maybe 140, 130, which is not tolerable. So we have given digoxin, which blocks the AV node, and they have reduced the rate to acceptable limits like 80 or 90. So that's why this patient was having an atrial fibrillation with a controlled ventricular response, not a tachycardia, because of digoxin, and they're having digoxin effect in the form of hockey stick ST depressions. That's all. Simple. So this is a digoxin effect, not a digoxin toxicity, basically. So I think I'm peaceful now because I've showed you the Scarbosa criteria and I've showed you the digoxin effect also. Fine. So as far as T waves are concerned, the most important thing is the tall T waves. Tall T waves are very, very important. As far as the tall T waves are concerned, so what is the importance of the tall T waves? Like what is the definition of a tall T wave? Whenever you want to tell a tall T wave, what is the definition? At least more than 5 millimeter in limb leads and more than 10 millimeter in chest leads, which means in the precordial leads at least more than 10 millimeter. And why not after, I mean, Bhavesh is asking, why not after giving digoxin P wave come again? I can't understand what you're telling. You're telling why P wave can't come again. Because digoxin does not control AF. They only control the ventricular rate by blocking the AV node. Problem in the AF is not in the AV node, it's in the atrium where digoxin does not act. More than 2/3 of the QRS. Yeah, that's a vague number, but usually this is the definition of a tall T wave. So clear? So more than 5 millimeter in the limb leads or more than 10 millimeter in the chest leads. So this is tall T wave. Remember, so tall T wave has many causes. The first cause you think is hypokalemia. In hypokalemia, remember, you will have a symmetric tall T waves. That's very, very important. So if you take the symmetricity, this will be pakka symmetric. So the upstroke and the downstroke will be very smooth. And this kind of symmetric peaking tall T waves is equal to hyperkalemia. Remember, even if you do not have a tall T wave, if you have a symmetric T waves, that is more going towards hyperkalemia. Asymmetric T waves, usually there will be a rapid upstroke and a smooth downstroke. That's a normal T wave. Rapid upstroke and a smooth downstroke. Like this. This is basically a normal T wave where if you see, if it's even asymmetric, even if it is tall, if it's asymmetric, is not equal to hyperkalemia. So do not diagnose hyperkalemia if the T waves are asymmetric in nature. That's a very important point. If the T waves are asymmetric, please do not diagnose hyperkalemia in that example. So more importantly, remember tall T waves can be produced by a variety of other causes apart from hyperkalemia. So it's the symmetricity that will differentiate whether the tall T waves is related to hyperkalemia or the tall T waves are not related to hyperkalemia. And the clinical picture will, of course, will tell. If there is a CKD patient, I'll think as hyperkalemia only. And of course, many other findings in the ECG also will tell whether the tall T waves are due to hyperkalemia or not due to hyperkalemia. Clear? That's why it's important. So then, of course, we are going to have T-wave inversions. So that's what we are going to discuss. What are the conditions that produce the T-wave inversions? And can you tell any other condition that can produce tall T waves apart from hyperkalemia? If you tell, I'll really like it. So what are the other conditions? From morning, we have been discussing one condition which can produce tall T waves. Yeah, hyperacute stage of a STEMI. All right, correct. Then what else? What else? Hyperacute stage of a STEMI. Yes. Then, simple LVH, left ventricular hypertrophy. Sometimes LVH itself can produce tall T waves. So that's why that point is also important. So 3 things you have to note as far as exams are concerned, it can produce tall T waves. Of course, first is hyperkalemia. Second is hyperacute stage of STEMI. And third is the left ventricular hypertrophy. Left ventricular hypertrophy itself can produce taller T waves without a doubt. All right. Yeah. What do you mean by intracranial hemorrhage is what you're talking about. So they can produce, not like it cannot produce. ICH can produce a variety of changes again. So now we are talking about T-wave inversions. So what are the conditions that produce T-wave inversions? Of course, T-wave inversions are normal in certain individuals. In certain leads, especially in V1 and probably in AVR. T wave inversions are absolutely normal, no problem at all. Absolutely normal. T wave inversions doesn't have any role in these leads. If you have a T wave inversion, that's considered to be normal in AVR and V1, so don't take it to be abnormal. And second, in young individuals, especially in pediatric children, in young individuals, there can be benign T wave inversions in V1, V2, and V3 sometimes, maybe plus or minus V4. So these leads can show T wave inversion. So this is what we refer to as something called a juvenile T waves. Juvenile T waves. And sometimes these T wave inversions can be taken into the adulthood also, especially in females. That is called as persistent juvenile T wave pattern. That's all. So there are two benign conditions. One is juvenile T wave pattern, and second is something called a persistent juvenile T wave pattern. Both can produce significant T wave inversions, and especially in V1, V2, V3, and V4. And remember, they are very benign, and usually the amount of inversion that they produce is less than 2 millimeter. Usually it will not be more than 2 millimeter. Very small inversions they will produce, not very big inversions, and usually it will be less than 2 millimeters seen in the V1, V2, V3, V4 leads. Typically in V2, V3, mid-precordial leads is where you see. And apart from that, T wave inversions can be seen in other conditions like right bundle branch block as well as left bundle branch block. We have seen already in RBB and LBB, you can see a T wave inversion, which we have discussed already again because of the discordance, concordance, all this stuff we discussed. I'm not going to tell you again. So what are the conditions that's going to produce T wave inversions? And of course, subendocardial ischemia once again can produce T wave inversion. Even STEMI can produce in the stage 3. But subendocardial ischemia is the most important answer as far as exam is concerned. Then, most importantly, acute CNS lesion. Acute CNS lesion. Whenever you have an acute CNS lesion, these are called as cerebral T waves or cranial T waves. So, for example, you can get in ICH or probably you can get in subarachnoid hemorrhage. You can get severe T wave inversion. These are called as cerebral T waves. The name is very important. So of course, you know the clinical picture here. The clinical picture here, patient will be in coma. If it's causing involvement of the ECG because of a cranial central lesion, of course the patient will be knocked out and he will be unconscious. So that is a cranial T wave or a cerebral T waves. And ventricular ectopics, tachycardia or all this stuff, they can produce T wave inversion because ventricular ectopics, we know they're going to produce bundle branch block pattern only. So there's no brainer again. So they can produce T wave inversions. And for that same reason, your RV pacing, which produces left bundle branch block pattern, also can produce T wave inversion. So you can keep on extrapolating whatever you have learned till now. And as far as the most important things are concerned, so this persistent juvenile pattern has been asked once in JIPMER. Then the subendocardial ischemia causing T wave inversions has been asked many times, especially in the setting of a critical LAD stenosis. You should not forget about something called a type B valence. Type B valence, which typically tends to produce this kind of deep symmetric T wave inversions. Deep symmetric T wave inversions. So that's something called as a type B valence, deep symmetric T wave inversions, which can happen in the evidence of a severe subendocardial ischemia. So we have discussed about some of the causes of T wave inversions as well. So you think what are the things that are left now? Is there anything that is left in the standard 12 lead ECG? I mean, arrhythmias are a separate topic. I mean, whether it comes into the ECG or doesn't come into the ECG is your wish to understand. Tired. Okay. Yes, you have found out. So two things are there. One is the QT interval and second is the, flat T waves, once again, hypokalemia. Flat T, I didn't tell no. Flat T waves, whenever they kill flat T, you talk about hypokalemia. Hypokalemia as a mnemonic, isn't it? One of the worst mnemonics you can see in hypokalemia. What is the worst mnemonic that you can see in hypokalemia? So there's a mnemonic called no pot, no tea. No pot, no tea. Which means if you do not have potassium, you don't get a T wave, which means T wave will get flattened. And T wave inversion will not happen. Basically, you will get ST depression, but U wave will come. So T wave, that's why I didn't write hypokalemia in the T wave inversion. Usually hypokalemia is not a very important cause of T wave inversion. They produce ST depressions, but not T wave flattening may be there. So that's the mnemonic. No pot, no T. So flat T wave is equal to hypokalemia. That's all. Fine. So when you call it as a giant T waves, giant T wave inversions. Giant T wave inversions means whenever you have a T wave inversion of more than 10 millimeter, more than 10 millimeter T wave inversions, or what we refer to as something called a giant T wave inversions, causes usually CNS lesions, that is nothing but cerebral T waves, CEREBRAL, cerebral T waves, and it can happen in type B Wallens syndrome, which you have discussed already. Type B Wallens syndrome, which you have discussed already. Then very rarely you can get in something called a apical HCM. That is apical hypertrophic cardiomyopathy, where you can get a giant T wave inversion. And sometimes in ischemia, post-STEMI also you can get some giant T wave inversions, especially post-ST elevation myocardial infarction. So more than 10 millimeter deep ST segment, T wave inversion. So these are the cause of giant T waves. Of course, if you want for exams, the CNS lesions and type B Wallens are going to be the most important. Most important, because that has been asked already. That's why these are the giant T wave, giant T wave inversion causes. So now we have only certain things left. We are almost coming to the end of the 12 lead ECG, and we have also discussed a lot of basics with this. So that's what is more important, because this is going to be forming the basics of what you're going to learn tomorrow. Because when I'm going to take heart failure, when I'm going to take STEMI and all, that time you should not be just thinking like what the hell is talking. So that's why I've told you a lot of stuff today itself. And before that, ECG and metabolic conditions separately. What metabolic conditions there? I'll tell today itself. 2 minutes. Metabolic condition. You need hypokalemia, hyperkalemia, hypocalcemia, hypercalcemia. That's all. No, hypothermia maybe. So still we have some more things to left, some more things to ponder. So right now, P wave done, PR interval done, QRS done, which is the biggest of all. Then we have done the ST segment. We have done the T wave, and we have to still do the U wave. We have to do the QT interval. We have to do the special waves, basically. And finally, we have only one more thing that is left: causes of axis deviation. Cause we did the axis, but we are not yet done with the cause of axis deviation. So we are going to do the cause of axis deviation. That's all. So as far as the U waves are concerned, U waves are a normal phenomenon, basically. If you in certain ECGs, but remember, it will be very, very small. Many times you will not be able to see. So if you are able to see the U wave, then it becomes pathological U waves. So suppose if you are able to detect the U wave, or if the U wave size becomes bigger than the T wave, then of course it is a pathological U wave. And in exam, if they ask you what is the cause of a pathological U wave, only one answer you should answer, that is hypokalemia. Everyone knows that. So this is the only thing they will ask you in exam: hypokalemia, cause of pathological U waves. And apart from that, U waves physiologically how they are generated, it is due to repolarization of Purkinje fibers. So this is the explanation that is given. Previously, it was thought that repolarization of the atrium is the one that causes U wave, but it's very clear it's not the repolarization of the atrium. Okay, are you seeing repolarization of the atrium here? So P wave is here, QRS complex, and T wave is there. Where is the repolarization of the atrium? Actually, repolarization of the atrium is not really seen, and it will come like this, basically. So actually, this is the atrial depolarization, what we are seeing. This is the P wave, and this is basically the atrial repolarization. This is the repolarization of the atrium. It should be something like this, what I have drawn in green here. Yes, but since it comes simultaneously with ventricular depolarization, normally it is not seen. Clear? It's quite simple. That's all. Okay. So now U wave we finished. So then we have QT interval, which is really, really important. As far as QT interval is concerned, so you have the QRS complex and you have the T wave. QT interval always carries some special role. So let us see what role it carries, QT interval. So, this is the QRS and this is the T wave. And if you start from the beginning of the QRS to the end of the T wave, it is what we refer to as a QT interval. So it includes the ST segment as well, basically. No, atrial also it is different only. Direction of repolarization, depolarization is almost going to be different only. Anywhere, depolarization in one direction means repolarization will be in opposite direction. This is a universal rule. They are like plus and minus, 0 and 1, I told you, North Pole and South Pole. And QRS and T wave, of course, both will be included, which means QRS is a sign of ventricular depolarization. And T wave is a sign of ventricular repolarization. So which means QT interval, I can tell it's nothing but the sum of ventricular depolarization and repolarization. So which means the time taken by the ventricle to depolarize and repolarize is what we are going to call it as a QT interval. That's all. That's the definition of a QT interval. The time taken for the ventricles to depolarize and repolarize. If you want to extrapolate in the form of an action potential, so now the QRS complex in the ECG will correlate with the phase 0. We know that is going to correlate with the phase 0, and the phase 1 J point will correlate. So let me put in different colors so that you will be able to understand easily. So J point will correlate with phase 1. J point will correlate with phase 1. Then you have the ST segment that is going to correlate with the phase 2 of the action potential. Then you have the phase 3 that is going to correlate with the T wave. That's a repolarization phase. And phase 4 is going to correlate with the isoelectric segment. That is the TP segment. We know that. So that's a segment. So we don't worry about that right now. So we know the action potential, how it is generated. Phase 0 is due to sodium influx, and phase 1 is due to potassium efflux rapidly. And phase 2 is due to two reasons. One is the calcium influx. At the same time, there will be potassium efflux as well. So two things are simultaneously happening here. So that's why it's an isoelectric segment. And finally, you have the phase 3, which is solely due to the potassium efflux. And there are many types of potassium channels in this area. You have R, S, I, so many types of potassium channels are there. I'm not going to complicate it. So you are having this potassium efflux that is going to generate the T wave. So that is a repolarization phase. So if I still wanted to merge with the ECG, this will be my QRS complex. So T wave, and it's going to be the, ST segment, and this is going to be the T wave. So phase 0, phase 1, phase 2, phase 3. That's the idea. And we have to, whenever you want to know the QT interval, it is important to know about where it's, what are the refractory periods. So you have something called absolute refractory period, and you have something called an effective refractory period, and you have something called a relative refractory period. What do you mean by absolute refractory period? What do you mean by effective refractory period? And what do you mean by a relative refractory period? You need to know. So for that, I'm using different colors again. So first, if you start from the QRS complex from this zone, and probably up to the maybe at the end of till the end of the second stage or second phase of the action potential, we generally tend to call it as something called a absolute refractory period, which means it starts from here and probably ends up till here. So where we are going to call it as an absolute refractory period. So why you call it as an absolute refractory period in the ECG as well as action potential? Because no matter how powerful you give a stimulus, the myocyte or any cell in this absolute refractory period cannot be excited. So that's why it's called an absolute refractory period. Then you have to know the concept of something called a relative refractory, effective refractory period. So what do you mean by effective refractory period? It extends into some phase of the phase 3, which means I can tell it extends into some of the T wave also in the ECG. So that is effective refractory period. So what is effective? What is the definition of effective refractory period? This is ERP, which means it extends a little more into the phase 3 also. This is effective refractory period. So what is the definition of an effective refractory period basically? So in the effective refractory period, if you give a stimulus, especially the suprathreshold stimulus, they might not be really able to develop a full-blown action potential. So in the effective refractory period, they will develop a new action potential. But they cannot be propagated. which means there will be only a localized action potential. They cannot be really propagated. So that is what we refer to as a effective refractory. In the absolute refractory period, they cannot produce or they cannot propagate. Nothing will work. But in effective refractory period, they can generate action potential, but they'll not be able to propagate. There will be only localized action potential formation. That is effective refractory period. And then we have an relative refractory period. I can write till the end of the T wave. There is something called the relative refractory period. This zone, this particular area is what we refer to as a relative refractory period. It is in the phase 3. Basically, it's in the T wave only. In the peak of the T wave to the little bit end of the T wave is where you're going to have a relative refractory period. So in this zone, it's considered as one of the dangerous zones, because here, if you give a supra-threshold stimulus, if the stimulus is supra-threshold, you can generate an action potential, plus you can propagate the action potential also. So that's a very dangerous area, which means if some new impulse is acting on this relative refractory period, you can generate and you can propagate the action potential also, which means they can generate new arrhythmias. Suppose if you put a new depolarization wave, suppose during the T wave, if you are generating a new action potential or you are producing a new depolarization signal that is falling on the relative refractory period. So this depolarization signal basically we called as R signal. R wave is the depolarization wave. According to most of us, we know that. And you are putting it on a repolarization wave that is during the phase 3 or on the T wave. That is what this is also referred to as something called a R on T phenomenon. Kamosho Cordis, Riju Dai. Kamosho Cordis, that is Kamosho Cordis. That is one type of mechanical R wave that you are giving, but R on T phenomenon doesn't only happen on Kamosho Cordis. R on T phenomenon can happen in a many other conditions apart from Kamosho Cordis. Should not tell that first. And I think you're a pre-final year or probably maybe maximum final year. That's where the problem is. So don't tell these kind of answers to the exam, even though a person like me might agree because I will see the correct thing in anything. But your examiners may not be like that. They will see only, like the problems behind that. So don't tell these kind of answers as the first thing. It's a typical UG's level kind of a question. UG's level kind of an answer where students literally burst out some answer, which is a very rare condition you don't really get, and you get caught in the exams. Don't do that. So it's an R on T phenomenon. Basically, R on T phenomenon. R on T phenomenon is dangerous. Whenever you develop an R on T phenomenon, which means you are producing a new depolarization signal on the repolarization area. Let me write this. This is a new depolarization signal on the repolarization area. And you're going to result in something called degeneration to malignant tachyarrhythmias. And you will go for ventricular tachycardia and ventricular fibrillation and all this stuff. And usually this is what we refer to as early after depolarization. So this depolarization signal on a repolarization wave is what we refer to as early after depolarization. And that's very dangerous. And after this, even more dangerous area is there. Like once you start the T wave, this zone, immediately after the T wave, a small end of the T wave, and to an extent in the isoelectric zone, there is one zone is there. This is called supranormal period. Have you ever heard of that supranormal period? What do you mean by supranormal period? Even less than ordinary stimulus can really propagate a signal very rapidly. And that is also an important area that can cause degeneration to malignant tachyarrhythmia. So that's called a supranormal period. So I have told you 4 periods. One is absolute refractory period, where no matter how much amount of stimulus you give, you're not going to get anything out of the stimulus, that particular area, particular myocyte. And second is the effective refractory period. In that small zone beyond the absolute refractory period, there, if you give a supranormal threshold, you can produce a localized action potential, but will not be able to propagate. Then you have the relative refractory period, the next some few small area that is especially fitting on the T wave, as I told you before. So if you are giving a supranormal threshold where you can propagate and you can generate a action potential, new action potential. So that's a dangerous zone because there is a risk of developing arrhythmias in that area. Immediately after the relative refractory period, in the phase 4, beginning of the phase 4 of the action potential, you are having something called a supranormal period where even less than ordinary stimulus or a less than threshold stimulus can produce a malignant tachyarrhythmia. So that is what we refer to as a supranormal period. So you have 4 periods here: absolute refractory, effective refractory, then you have relative refractory, and you have the supranormal period. All four has to be very clear. So what do you mean by what is the problem in long QT? So now you can easily understand what's the problem in long QT. So now if you have a long QT means you're going to have a slower depolarization and repolarization. Most importantly, you'll have a very slow repolarization, which means phase 3 will be prolonged, and which means the T wave will be widened. So that is the problem in in your long QT syndromes in the first place. So if you want to draw the action potential, your action potential is going to be something like this, which means it's a very long action potential. And more importantly, most of the times, the reason for this prolonged action potential will be due to slow efflux of the potassium channel. So it will be happening for a long time. So that is the reason why T wave is prolonged here. So this is one example of very slow action potential where the phase 3 is significantly widened. The slope of the phase 3 is significantly increased so that it takes place at a very low speed, and that is the reason why you are having a lot of problem here. Which means what I'm typically trying to tell is the absolute refractory period will get over here, the effective refractory period will get over here, and if you see the relative refractory period, it's too much. So which means your vulnerable zone is very, very high. So there is an increase in relative refractory period. Because there is too much of relative refractory period, this zone is highly vulnerable, and supposedly if there is any new stimulus that is falling on this area, there is increased chance of developing a new arrhythmia. So that is why long QTs are dangerous and they can produce sudden cardiac death. Very, very important point. That is because you are increasing the relative refractory period, you are increasing the T wave length, and you are increasing the risk period where you can supranormal period be absent in sinus tachy and P wave merges with it with T? I can't understand. I'll discuss with you later on about that. Even I should be hungry, right? I'm talking from the morning. Okay. So relative refractory period. So where you produce a new depolarization signal on it, and there is a lot of chance that you might develop a tachyarrhythmia. Remember, when you have an action potential, so this is a depolarization, and this is repolarization. We know that. Suppose if you develop if you produce a new depolarization signal over here, what is this called as? On phase 3, you are generating a new depolarization signal. Due to some reason, you are producing a new depolarization signal. What is that called as? What is that called as basically? That's not premature. These are called as after depolarizations. Depolarization that is coming after a depolarization. That's why it's called an after depolarization. If you do it on phase 3, maybe in the phase 2 or phase 3, that's called early after depolarization. If you're going to do on phase 4, that is called as a delayed after depolarization. The name super, they have kept it in a very nice way. So that's an after depolarization. After depolarization, you're creating a depolarization. That's why it's called after depolarization. So if it happens in phase 2, 3, then it's early after depolarization. If it happens in phase 4, it is delayed after depolarization. So usually, if they ask you what is the mechanism of arrhythmia in long QT, why you develop an arrhythmia in the first place, it is due to early after depolarization. Most of the time, there will be early after depolarization. Why? Because it's very simple. Because the phase 3 is the one that is most often prolonged in long QT syndromes. Because the phase 3 is prolonged, there is a risk of developing R-anti phenomenon. There is a risk of developing a new depolarization wave on the repolarization wave, and that should be falling on the phase 3 only. That's why EAD risk is very high in long QT, and that is the reason why they go for ventricular tachyarrhythmias. If somebody asks you what is the characteristic arrhythmia of a long QT syndrome, what is the characteristic arrhythmia of a long QT? What is the characteristic ventricular tachyarrhythmia you will develop in a long QT syndrome? Yes, Torsades. Torsades pointer. So there is a characteristic arrhythmia that you're going to generate in a patient with the long QT syndrome. Suppose if I ask you one question, you have polymorphic ventricular tachycardia and Torsades. Both are different or both are same? They are different or they are same? PMVT and Torsades. A small difference is there. Polymorphic VT, the name should be there if it's happening in a patient with a normal QT interval. Suppose the same PMVT, Torsades, if it happens in the patient with a long QT, it should be called as a Torsades, which means almost they are the same only. At what situation it happens is what is going to differentiate whether it's a Torsades or a PMVT. A normal QT causing this type of tachycardia is just a polymorphic ventricular tachycardia. On the other hand, if it's a long QT and that produces the PMVT, that polymorphic VT type of a picture, that long QT related PMVT will be called as Torsades. So which means it's a type of PMVT only. That's correct. Clear? Classical arrhythmia of a long QT syndrome is Torsades pointer, and classical arrhythmia of early after depolarization is Torsades pointer only. That's why this is really important. So now, after knowing about so many things about Torsades and this is the long QT syndrome. Now the final thing is to know about the causes are very important for exams. What are the causes that produces long QT? So you have long QT and you have short QT. Short QT is not that important, to be honest, but long QT is really important. So long QT you can classify into congenital long QT causes, and you have acquired long QT causes. Acquired long QT cause is going to be the most common. So that's going to be the most common. And congenital is very rare. Congenital you can split into two types. One is you can think about something called what is that? Jervell-Lange-Nielsen. I think hypoglycemia. Jervell-Lange-Nielsen syndrome. Jervell-Lange-Nielsen syndrome or JLN syndrome. Basically, this is an autosomal recessive disorder, and the patient will be having deafness. And this is a very important clue in exam. Deafness, autosomal recessive inheritance, Jervell-Lange-Nielsen syndrome, long QT. And usually it is due to potassium channel defects. Most of the Jervell-Lange-Nielsen syndromes will be due to potassium channel defects only. And then you have Romanov-Watt syndrome. Romanov-Watt syndrome. Romanov-Watt syndrome is basically autosomal dominant, and they really do not have deafness. So that's the very defining criteria. So very important differentiation as far as exams are concerned. And most of the Romanov-Watt syndromes also will be having potassium channel defects only, and most commonly, again, it's due to potassium channel defect. But here it's only potassium channel defect, but it's most commonly potassium channel defect as far as Romanov-Watt syndrome is concerned, which means Romanov-Watt syndrome can have problem in the calcium channel, sodium channel, any channel can have problem as far as the Romanov-Watt syndrome is concerned. But on the other hand, your Jervell-Lange-Nielsen syndrome is characteristically due to only the potassium channel defect. So now Romanov-Watt syndrome can be further subdivided into many different types. For example, you have many different types of LQTS. Long QT syndromes 1 till 16 has been there. Even 17, 18 also has been told by some textbooks. Okay, Ashwin, sure. So I think I'm in hypoglycemia. That's why my handwriting is also going a little small. So long QT syndrome 1 to 16 is there. But if they ask you the most common type of long QT syndrome in the world, of course, the answer is LQTS type 1. So basically, if you want to know about LQTS type 1, LQTS type 2, and LQTS type 3. So these are the three things that you basically want to know. LQTS type 1 is due to the potassium channel defect. LQTS type 2 is also due to potassium channel defect, but LQTS type 3 is basically due to sodium channel defect. And this is really important because LQTS type 3 is due to defect in the sodium channel called as SCN5A. So where else you will get SCN5A defect? Where else you will get? So it's a sodium channel defect. You're talking about Brugada syndrome, man. Brugada syndrome. Clear? Brugada syndrome. So which means, remember, you should not confuse this. Remember, and one more important thing to tell is Brugada syndrome is basically not a long QT syndrome. Brugada syndrome is completely different from LQTS type 3. Remember, all these are going to produce long QT in the ECG, whereas Brugada syndrome is definitely not going to produce long QT. Brugada syndrome is not a long QT syndrome, but you have some close association with Brugada syndrome. That's why. So if you ask where they will develop ventricular tachyarrhythmia, what is the trigger for ventricular tachyarrhythmia in these patients? That's very surprising most of the times. In LQTS type 1, the trigger will be usually in the form of loud noise. Suddenly when they tell some loud noise, they'll go for ventricular tachyarrhythmia. That's a trigger. As far as LQTS type 2 is concerned, usually diving, swimming, this will be the triggers. As far as LQTS type 2 is concerned, as far as LQTS type 3 is concerned, they usually die at rest itself. There is no trigger. Sleeping, rest itself, they will die. So that is why Brugada syndrome is also special, isn't it? Even Brugada syndrome, the patient die at rest and they die at sleep. And LQTS type 3 patients can have the same picture, but the major difference between LQTS type 3 and Brugada syndrome is the fact Brugada syndrome is not a long QT syndrome. And Brugada syndrome will have a completely different ECG picture, and LQTS type 3 will have a completely different ECG picture, even though the gene mutation is the same. Clear? This is something very important to understand. So both patients have a similarity in how they die. But remember, LQTS type 3 is completely different in the fact that they are going to have a long QT, whereas Brugada syndrome is not a basic long QT syndrome. Clear? So fine. So these are the congenital causes which you need to know. So to some extent, but most of the times your exam questions will be based on this differentiation between Romanov-Watt syndrome and your Jervell-Lange-Nielsen syndrome only. Then we have acquired causes of long QT. Acquired cause of long QT, you have few causes. Let me finish off with the causes alone. Acquired causes. Acquired causes, first the 4 hypos. I need to know the hypos. What are the 4 hypos you need to know? One is hypokalemia. Then you have hypocalcemia. Then you have hypomagnesemia. And remember, hypothermia. These are the 4 hypos that you need to know. Hypokalemia, hypocalcemia, hypomagnesemia, hypothermia. All these things can produce long QT. Remember, hypermagnesemia also can produce long QT. It's not only hypomagnesemia can produce, hypermagnesemia also can produce long QT syndromes. And apart from this hypos we are talking about, there are a lot of other causes that can produce long QT. More importantly, the drugs. The drugs are very, very important. That can cause long QT. Many, many drugs can produce, right from your antihistaminics. Clear? Antihistaminics can produce long QT. Especially that is the reason why. Your drug terfenadine, not terbinafine, terfenadine has been banned from the market. That's an antihistaminic that is not used. Now we use fexofenadine, but we don't use terfenadine. So that's because of effect of sudden cardiac death because of long QT. So especially older generation antihistaminics have a higher propensity to cause long QT compared to the newer generation antihistaminics. Then we have antipsychotic drugs that can produce long QT, especially the older generation antipsychotics cause more of long QT compared to that of newer generation antipsychotics. Newer generation also can produce, but older generation are more like haloperidol and all. And newer generations like risperidone, ziprasidone also to an extent can produce long QT. Then antibiotics can produce long QT. What are the antibiotics that can produce long QT? You can get with quinolones. Very important, because I used to tell quinolones as a mnemonic, one of the important side effects of quinolones is long QT. That's why the name Q, it starts with the letter Q. So quinolones can produce long QT, especially gatifloxacin is known for its potential. Gatifloxacin is removed from the market for systemic use. Now only for local use they are using for eyes and ears. For systemic use it's not used. Because why we don't use for, I'll discuss, come to you Nilashish, because you're asking a doubt. So systemic use, we don't use gatifloxacin because it's going to produce severe neurotoxicity, and at the same time it's a risk of producing long QT. So that's why we don't use quinolones. Then macrolides, especially clarithromycin, very notorious. They can produce long QT. And then we have a lot of anti-tubercular drugs, ATDs, anti-tubercular therapy, like especially the newer anti-tubercular drugs. That's what we need to know here, like bedaquiline and delamanid. We know these drugs, isn't it? Bedaquiline and delamanid can produce long QT. So this is a very important question for exams. Anti-tubercular drugs can produce long QT. And HIV protease inhibitors. The highest is going to be sacubitril, but any HIV protease inhibitor can do that. But you can remember the mnemonic again. Sacubitril once again has this Q in it. So sacubitril is important. Apart from antibiotics, we have some anti-inflammatory drugs. Before COVID, I would not have told this, but since it's COVID, I'm talking about HCQ here. So HCQ can produce some anti-inflammatory drugs like HCQ can produce long QT. And apart from that, you have anti-arrhythmic drugs itself, which can produce long QT. So what are the anti-arrhythmics that can produce long QT? Yes. Remember, there are two antiarrhythmics which block the potassium channels. What are the potassium channel blockers? Remember, whenever there is a blockade in the potassium channel, your phase 3 is going to get prolonged. We know very well. The reason for one of the main reasons for phase 3 getting prolonged is the potassium channel blockade. That's why the potassium leaks very slowly going out for a longer period of time. We know that. So what are the potassium channel blocking agents? Of course, the name itself tells in the Vaughan-Williams classification, class 3 is the potassium channel blocker, and they're going to produce the maximum QT prolongation, of course, among all the antiarrhythmics. This will be followed by class 1A drugs. Class 1A drugs, they also block potassium channels to some extent. So what are class 1A drugs? You have prokinamide, you have disopyramide, you have quinidine. So these are 3 drugs that come under class 1A drugs. So all these antiarrhythmic drugs can produce long QT. So class 3 followed by class 1A drug. I think we have learned about the acquired cause also, but remember there are a lot of other drugs are there as well, but I am just summarizing and compiling the important drugs that are important for the exams, which can produce long QT. And you have a separate net, like internet site is there, longqt.org, where you can go and check and you can find out what are the conditions what are the drugs that are going to produce long QT. And as far as the short QT is concerned, very few causes are there. You have short QT syndromes also, but what is the significance of short QT syndromes? We have absolutely no idea in the world because they're very much less common. And at the same time, hypocalcemia is going to produce long QT, but hypercalcemia is going to produce short QT. This is a very, very important question in exam. Many times they will ask like kind of exception kind of a thing. All of the following are true with hypocalcemia, except they will give short QT, and that's a wrong answer because that's the right answer because it's a wrong statement. Hypocalcemia will cause long QT only. Hypercalcemia will cause short QT only. And you have digoxin use and hyperkalemia. So you can remember hypokalemia here. You can remember hyperkalemia here. Digoxin use, hyperkalemia, hypercalcemia, and short QT. Among all these 4, if you take the most important, it's going to be always the hypercalcemia and the hypocalcemia. That's very, very important as far as the long QT and short QT is concerned. So now we know the cause of long QT, cause of short QT also. Remember, long QT always has a risk of sudden cardiac death. Even short QT has, but long QT has been traditionally established. Long QT has a very high risk of developing sudden cardiac death. And there's too much high risk of sudden death with long QT, especially with the congenital syndromes, you can develop long QT. So what is the normal QTC? We didn't really think about that. What is the normal QT interval? So remember, QT is a problem because you cannot usually use the QT interval directly because QT is going to change with heart rate. I mean, for example, if you have the action potential like this, so remember the action potential duration is the one that's going to be equal to the QT interval. We know that. So if this is a normal heart rate, in tachycardia, it's going to happen like this. So which means at increased heart rate, you know very well the action potential duration is going to be shortened and the QT interval also will be shortened. So QT interval shortening is very important and essential for, to increase the heart rate. If the QT shortens only, then only you can produce more heart rate. Similarly, when you have a lesser heart rate, there will be increase in action potential duration and the QT will prolong. So what I'm trying to tell is QT interval is subjected to changes in the heart rate. So because QT interval is subjected to changes in the heart rate, there is a need to find out a standard QT interval, and that is what we refer to as something called a corrected QT interval. So what do you mean basically by the corrected QT interval? QTC, you are correcting the QT interval according to the heart rate. So whenever you tell about a normal QT interval, you should always tell a corrected QT interval. Riju is asking when the class will end. So it will end in some time. So normal QTC is what we want. So what about, what is the normal value of the QTC, normal corrected QT interval? It is somewhere around 0.35 to 0.45 seconds. This is average, but even though the upper limit of average is different for males and females. For males, you can keep a cutoff of maybe 0.46 seconds, and for females, you can keep a cutoff of 0.44 seconds. But average I'm taking, it's around 4.5 seconds. But remember, significant problems will start only if the QT interval is beyond 0.5 seconds. Only if the QT interval is beyond 500 milliseconds, or if the corrected QT interval is beyond 0.5 seconds, that's where you're going to result in problems. You're not going to result in problems otherwise. Just because you're going to have a QT interval of 0.45 or 0.46, you will not have problems. Most of the times the problems will start, and arrhythmia's risk is very high only if the QT interval is typically beyond 0.5 seconds or 500 milliseconds. How will you find out QTC? You have something called a Bezet's equation. Bezet's formula. This is a traditional formula. This is what they're going to ask, where they tell corrected QT interval is equal to QT divided by square root of RR interval. That is the corrected QT interval according to the Bezet's formula. Remember, this formula can be used only if the heart rate is less than 100 BPM. So if the heart rate is more than 100 or heart rate is extremely low, like 20, 30 and all, this formula will break down. So this is not an accurate formula in that setting. So in the normal heart rate, this will be a very good formula. And apart from that, you have the linear model equation. Linear model, so which tells QTC is equal to QT plus 1.75 into heart rate minus 60. So this will be okay for higher heart rates. Whenever you want to calculate QTC for a higher heart rate, then this linear model may be useful. But for all practical purpose in the exam, they will be asking only Bezet's formula. Remember, even in my JIPMER exam during my time in 2010, they used to ask this kind of, Bezet's formula only. So they will give 4 equations and they will tell which of the following is true with Bezet's formula. You have to tell QTC is equal to QT divided by square root of RR interval. That will give the corrected QT. So what is the definition of short QT? We know it's a long QT. Anything more than 0.46 seconds as far as males are concerned, and anything more than 0.44 seconds as far as females are concerned is what we refer to as long QT. And what do you mean by short QT? Anything less than 0.35 seconds is what we refer to as short QT. We know that. And as I told you, problems will start in 2 areas. Either if it's more than 0.5 seconds, the problems will start significantly wider, or if the increase from the baseline value by at least 0.06 seconds, or we can tell the 60 milliseconds increase from the baseline. For example, patient may have a QT of 0.36. So because of some reason, suddenly it become 0.43. This is also a risk factor for arrhythmia. It's not only, cardiology or anything in our body is only relative. It's not always absolute. I've seen a lot of long QT patients with QT of 0.5 to congenital long QT syndromes where they don't develop arrhythmia. We just wait and watch. They have crossed even their adulthood. They don't develop arrhythmia. So it's all about the relative increase. So even increase by 0.06 seconds, 60 milliseconds acutely because of some drug has a higher risk of developing long QT syndrome. So this is the basic equation for a corrected QTC interval. So if it is less than 0.35, we call short QT. Anything more than 0.45, you can think as long QT, but problems will start if the QT is more than 500 milliseconds or if the increase is by 60 milliseconds from the baseline, that too which is happening very suddenly. So that is a sign of a long QT. Clear? Finally, I'm going to show only one ECG. So we are going to continue tomorrow only. Finally, I'm going to show only one ECG. This is the ECG of a long QT. Yeah, this is an example of ECG of a long QT. So how to find out long QT very easily? I used to tell a trick basically most of the times. So what are the, ways, or what are the methods to find out the long QT here? So remember here, if you take the QT interval, so for example, this is where you start with and this is where you end with. So if you take the actual QT interval, and if you want to find the corrected QT, you have to take the actual QT interval, divide by, you have to take the RR interval and take a root of it and find out, and you will be doing only one thing in the exam. And this is the only thing you will be solving in the exam. You will not be solving anything else. So don't do that. So there is a easier way to find out this. What is the easier way to find out a long QT interval is very simple. So you just take I don't want to use green. Let me use this. You just take the two RR intervals and just try to take the midline, approximate midline, and just try to draw a line over there. And if you see that the end of the T wave is falling beyond this midline, it's very likely to be a long QT. And this will be very, very correct, especially if the patient is in sinus rhythm and if the heart rate is less than 100, this will be perfectly correct. Perfectly correct. It will not fail at all. It's my tested thing. Definitely. You can go anywhere and see. So this is something like a long QT. Draw a midline. I don't know, I'm biasing maybe. I'm going a little away. So maybe midline. And definitely this is a correct midline, and you see the T wave will fall beyond that the midline I'm drawing hypothetically. So this is a long QT. So if you want to test it, take one more random ECG. Let us see. Not an arrhythmia. I need a random ECG. Okay, this is a random ECG I'm taking. I don't know what is this ECG, random ECG one. So where I want to test my hypothesis. So you have R wave, you have an R wave, and you definitely have, RR interval. I'm drawing a line, and in the midline, I'm taking a hypothetical line, and you can clearly see the end of the T wave is falling before that midpoint only. Yeah, pacemaker ECG only. I don't know. I'm just taking a random one. So this is not a long QT by any means. I cannot tell this is a long QT. Or take another ECG, anything, whatever you want. These are all MI. MI will definitely have something different. Maybe you can take this ECG. I don't know. What is this ECG right now? Some random ECG I'm taking. You just see what's happening here. You take, this is the T wave. And you take the midline. And definitely how much ever I draw, closer to it, it is going to fall before this midpoint only. It cannot be falling after the midpoint. 100% it is not a long QT. So, but the original long QT that we saw here, this is definitely long QT, because as I told you multiple times, here the midpoint what you're drawing is going to fall definitely before the T wave. So which means the T wave, end of the T wave will be falling after this midline. So if you have this kind of stuff, so this is definitely a long QT only. So it's very easy to find out. In exam, when you want to find out long QT, most of the time there will be some drug they will give. Please understand this is a very important thing. Drug they will give that increase the long QT, and they will give that the patient is using an enzyme inhibitor. They will not give the enzyme inhibitor directly. The name enzyme inhibitor, they will give some drug that produces this enzyme inhibition. So for example, very commonly, let us take a COPD patient or bronchial asthma patient. They have given maybe clarithromycin, which is a macrolide which can produce long QT, because the patient has acute exacerbation of COPD, where I use macrolides very commonly, clarithromycin. And let us assume the patient is taking azoles. Maybe the patient is also taking a fluconazole simultaneously. Fluconazole is a very powerful enzyme inhibitor. That's not a long QT drug, but that's a very powerful enzyme inhibitor. So now there is a lot of drug interaction that is happening. Because of this kind of drug interaction, this fluconazole, this fluconazole has significantly increased the QT, and that is the reason why the patient has died of sudden cardiac death. So in the exam, you will be getting long QT questions in the form of drug interactions very commonly. So where I told you there will be a drug that produces QT prolongation, and there will be a drug that produces cytochrome enzyme inhibition, the CYP enzyme inhibition. So this will be another drug. So you know what are the enzyme inhibitors? Azoles, very powerful enzyme inhibitors. Then you have clarithromycin, and macrolides itself is a very powerful enzyme inhibitor. Then you have other enzyme inhibitors like protease inhibitors. HIV protease inhibitors are very, very important. They are very powerful enzyme inhibitors. So there will be some drug that inhibits the enzymes, and there will be some drug that increases the QT. And when combined these drugs, the QT will increase significantly, and acutely it will increase, resulting in ventricular tachyarrhythmias and death. And it can cause sudden death also. That's why you have to be a little careful. This is the first kind of a question you will get in exam. Be very, very careful. And the second kind of exam, what you can get, second kind of question, what you can get in exam is a congenital long QT. A congenital long QT syndrome, usually will either have an exertion, some kind of exertion, followed by ventricular arrhythmia, which can result in a syncope. And ECG, if you take, may show a VT or a VF, or they can have a sudden cardiac death also. Any symptom, any of this can be positive. Sudden cardiac death also. And more importantly, if it's a congenital syndrome, you'll have a strong family history, which is very, very important. And congenital long QT can come at rest itself. Whenever it comes at rest, you have two diagnoses. One is Brugada and second is LQ2S type 3. Remember, if you really want to diagnose LQ2S type 3, you should have a long QT in the ECG. You'll have a long QT in the ECG, and Brugada will not have a long QT in the ECG. So it cannot be considered as a long QT syndrome. But both LQ2S type 3 and Brugada syndrome patients can die at rest. That's the most important point here. So that's why I told you. So they die at exertion, some noise, some diving, swimming. During that time they die. Think about a Romanov syndrome, that is LQ2S type 1 and type 2. If it's rest, then think about LQ2S type 3. If the patient is having associated deafness, think about Jervell-Lange-Nielsen syndrome. So congenital, family history, deafness, long QT, sudden death, Jervell-Lange-Nielsen. Congenital, no deafness, death during exertion like loud noise or your swimming, diving, think about LQ2S type 1 or 2. At rest, think about Brugada versus LQ2S type 3. Brugada will not produce like long QT only, and it will have a classic ECG which I'll show tomorrow. And then LQ2S type 3 will have the ECG which I've shown. So that is actually an LQ2S type 3 patient only, and they will not have deafness. So these are the differentiating points that you have to know. And most commonly in exam, more than the congenital long QT syndrome, you will get the drug interactions only. So please be very careful about the drug interaction and list of long QT along with the list of enzyme inhibitors that you're going to see. So with this, I'm going to finish it off the today's session. Let us discuss tomorrow. Thank you very much. Tomorrow, same time, 10 a.m. Thank you. Good night. Tomorrow cardio will be over, man. I'm not going to carry on cardio forever. See you. Tomorrow cardio only. I'll be starting with arrhythmias mostly. Once I finish arrhythmias, you have ischemic heart disease, cardiomyopathies. These are very small topics. Ischemic heart disease is there. Then cardiomyopathies are there. Then to some extent you have the aortic problems. Aortic problems are there, and some important clinical stuff only I will tell. Hartson's and JVP, I think you are this thing, no, final year student, no, that's why you are thinking about Hartson's, JVP and all. Valvular heart disease, I have covered in a lot of other areas in free class itself. So I'm not planning to cover valvular here, which I'll be doing only the important stuff. This is a neat class. Please understand that. Endocrine one day is more than enough. There is nothing to discuss in endocrine much. And don't really confuse your app videos with this video. Like app videos are completely different. Whatever we have discussed in app is a different kind of an extreme. Like where there we are going to discuss, like the practical stuff and a lot of clinical stuff. But what we are discussing here is only the MCQ stuff. Just go today and see what's really happening there and put some questions. You will understand how much you are able to do. So many points I have covered. A lot of things, whatever I told you, are actual MCQs. And when you take the textbook and open it and solve the MCQs, that time you will be understanding the things much better. Please tell the enzyme inhibitors again. So there's nothing to tell in that. I told you multiple times. Usually you will have a drug that produces QT prolongation. I'm writing third time. And you're going to have a drug that produces enzyme inhibition. So when you combine this, of course, this drug that produces enzyme inhibition is going to increase the levels of this drug. And because of the increased levels of this drug, there's going to be a sudden increase in the QT, resulting in arrhythmias and death. That's all. Examples. See, examples, QT prolongation drugs, I told you already. Enzyme inhibitor drugs, yeah, very commonly in exam, they'll give azoles and HIV protease inhibitors only. These live class notes and question solving alone as a primary source. Yes, you can use. Till now, they have been using like that only. Till now, as far as I know, my students used to tell whatever the notes they take and whatever they attend till now, I mean, the 10-day or 12-day classes, whatever I take, they were supposed to attend like at least 80 to 100 questions in the NEET. So that's what they told last time. I don't really know, but that's what they told me. 80 to 100 questions they were able to open just because of 10 to 12 days of class. So don't take it lightly. All these are important, whatever I told you. See, usually when you study or when somebody listens to your notes for the first time, whatever you write and show, this is Dilip sir's class, it look very haphazard. Because I discuss in my own way, in my familiar way, where I take the topic in a different way. So like I start with blood flow and I take in a very different way. So I don't start with, like heart failure means I discuss with epidemiology, pathophysiology, clinical features, investigations, management. So you have textbooks for that. So why do you need me? You need me to have that orientation towards a particular topic, and you need me to tell the points that are important, and you need me to crack the exam. So this is what you need as far as this particular session is concerned. So that's what I'm going to concentrate on. So don't worry about that. So we're going to do a lot of cardiology tomorrow. Good night. Bye-bye. I'll tell something. So we have some clarity about JVP, and you will be having some clarity about JVP and heart zones. So don't worry about that. Yeah, tomorrow we have special waves. Special waves. Then after special waves, we'll be discussing on the arrhythmias. After arrhythmias, we'll be moving on to ischemic heart disease. Mostly by 7 o'clock or 8 o'clock, we should be able to finish cardio, according to my guess. Bye-bye. See you.